and wish everyone a productive and enriching session. I would request Dr. Bhumika Madhav ma'am for the welcome address.
Good morning, everybody. Good morning. Good morning. It gives me immense pleasure to welcome all of you to today's academic event. I would like to extend a warm welcome to our respected dignitaries, distinguished faculty members, panelists, colleagues, and all the delegates who have joined us today. Sleep apnea is no longer a condition that can be dismissed as simple snoring. It is common yet frequently underdiagnosed. It can affect the patient's quality of life and is closely associated with hypertension, cardiovascular disease, metabolic disorders, obesity, and daytime sleepiness. Early recognition and appropriate treatment can make a remarkable difference in the patient outcome. The aim of today's program is to bring together experts from different specialties, share practical clinical insights, discuss newer advances, and understand how we can diagnose and manage sleep apnea. Thank you.
Next up, I would like to request our first speaker, Dr. Anuradha Shah ma'am, and the chairperson for this session, Dr. Ravindranath Sahai sir, to come up on the podium. I would also request Dr. Sangeeta for the same event to chair the same event. Please, ma'am, come up on the podium. Start your presentation.
So nobody is going to introduce me. Dr. Sai is supposed to introduce me.
Yeah.
Then? That's one title with me. This one. Yeah. No, first. Right on top. You have to go on top. Yeah. So nobody is going to introduce me. When? I know. That's it. No, it's already saved. It's saved. Save ho gaya. Give him the... Is there a pointer?
Good morning, everyone. Today's whole day's session is on sleep disorders and sleep. So, to set the ball rolling, the first topic is best to understand the circadian rhythm with which sleep is related and some abnormalities just like jet lag, which all of us have experienced and wonder what it is. So as I said, to set the ball rolling, you can't have a better speaker than Dr. Anuradha Shah from Bhatia Hospital, who has 30 years of experience in sleep disorders, and she's also the consultant physician there. So without spending more time, Dr. Anuradha Shah, the stage is yours.
Thank you for that kind introduction. At the outset, I'd like to thank Dr. Jayalakshmi and her team here at Apollo to invite me to speak on this very interesting topic of circadian rhythm, jet lag, and performance optimization. So what really is circadian rhythm? Circadian rhythm comes from this You're not able to see? Pointer's not working. So circadian rhythm comes from this Latin word called circadian. That's about a day. So what does it do? It actually regulates sleep and wake timing, body temperature, hormone secretions, especially melatonin and cortisol, blood pressure, immune function, metabolism, and even mood. So how does this occur? So basically, there are genetic time markers. Yeah, thank you. It's not projecting, no? It's too bright. Yeah, even this is working here. But it's not projector on this. Yeah, that's okay. So basically, there is a clock called the master clock. Okay? So that sits at the optic chiasma, at the base of the hypothalamus. Okay? Just above the optic chiasma. And it's called the suprachiasmatic nucleus. That is the most important clock in our body, and that drives all the 100 different organ or molecular clocks that are there in the body, okay? So what does this clock do? It gets light through the retina, which goes through the retina hypothalamic tract, and that's the most important signal, light. And then what the clock does, it sends signals downstream. There's a huge echo. Are you all hearing me well? You all are okay, right? Because I'm hearing myself repeat. So there's a signal that goes downstream to all the different clocks that are in the different parts of the organs, whether it's the liver, the gut, the muscle, the skin, immune, okay? So this sends secretions and it monitors. So what do I mean by that? So basically, the most important thing is that time is a fundamental biological dimension. Ignoring it can disrupt health, and respecting it can improve health function. And why do I say that? Because of the various peripheral clocks that are there. Okay? So what do these clocks do? They control body temperature, they control the sleep-wake cycle, they control hormone metabolism, cardiovascular function, immune function, and most importantly, metabolism. So the central clock sends signals to the peripheral clocks. These are what happens within the peripheral clocks. There are genes. There are a couple of genes involved. The most important is the clock and the BMAL1, okay, which activate what is called transcription, send signals all over the body to understand the various processes. Then, as it's activated, the PER and the CRY genes repress it. So once a particular level of transcription, takes place, then the PER and the CRY protein accumulate, they switch off the loop, they are degraded, and the cycle starts again and again and again. And this clock, this molecular clock, works every 24 hours. And that is the most important thing for everybody to understand. If I had more time, I would have gone into how it can disrupt and cause each and every disease in the body, okay? Disruption of this clock. So from cancer down to cardiac problems, it is the molecular clock that goes out of sync. So like you can see that figure, the key components on the right side, the BMAL1 partners with the clock, activates the target gene. The clock gene is the transcription factor that drives the clock. The PER and the CRY then get enhanced, then they repress, and then regress, and then reactivate, okay? So why is this important to understand? Because if there is a problem in this transcription whole cycle, then the body has all the health issues that we talked about. So what are Zeitgebers? Zeitgebers are the time givers. These are the ones that reset the clock in the body, okay? The most important Zeitgeber is light, okay? Bright light, daylight is the most dominant Zeitgeber. It shifts the clock via the melanospin containing retinal ganglion cells that project to the suprachiasmatic nucleus, and the morning light advances the clock. That means it moves it earlier. The evening light delays the clock. So what does that mean? That's the reason why we say at night, wind down. Dim the lights, don't look at screens, don't look at blue light, don't look at television, and wind down. Why do we say wind down? Because we want all our clocks to also wind down. That's the time melatonin is secreted in the body. And when melatonin is secreted, its peak is around 2 a.m. That's the time you've got to be in the deepest sleep. And then slowly by 6 a.m., melatonin is gone and you're supposed to be awake. And that's why the dictum came 10 p.m. to 6 a.m., which our grandparents followed beautifully, and they didn't have health issues like what we are having today, right? We are exposing ourselves to so much artificial light. How can our clock get set? Remember, light is the biggest Zeitgeber, okay? The next is the melatonin. It's secreted by the pineal glands only in darkness. That's why we say, as the sun sets, melatonin starts rising in the body, okay? So it's darkness. That signals that now it's biological night, and it shifts the clock in the opposite direction. So the purr and cry genes get activated, repress BMAL and clock, and the night shifts, and then you go to sleep, okay? So it shifts the clock in the opposite direction. So if you take melatonin in the evening, okay, it will advance the clock. Okay, if it's taken in the mornings, it will delay the clock. So that's why we give melatonin at night. What about social schedules? They are important. So we know that regular meal, regular exercise. Why? Because the body has clocks. Our gut has a clock. The gut, the liver, they all have clocks. They're supposed to metabolize the food. You can't have dinner at 11 p.m. and then go to bed at 12. Apart from the fact that you will get acidity, you're throwing your clock out of sync, basically. Yeah? So I'm sorry the pointer doesn't work, but just please look at the graph, okay? Look at the timing from 0 to 24 hours. And what are you seeing? Alertness, 6 a.m. onwards. You're most alert first thing in the morning, and your function goes down. Okay? Cognitive function, which is the green graph, slowly improves, and it is peaking till 6:37 and then goes down. Physical performance. Okay? See how it goes. Okay? It peaks actually early afternoon, evening, and goes down. And the last but not least, reaction time. And so our function through the day, learning, memory, optimum 9 to 11 a.m., reaction time 3 to 6 p.m., strength 4 to 7 p.m., endurance late afternoon, fine motor skills, morning to midday, and sleep drive after sunset, right? So all the hormones work accordingly. So you analyze and think better first thing in the morning. Midday, you're able to make decisions. Your strength is maximum in the early afternoon. And at night, you have the highest fatigue risk. Okay? So we've got to remember that, and we've got to behave accordingly. What happens when the clock gets disrupted? And that's what modern life is all about, right? We are forever disrupting our clock. What are we doing? We're working in shifts. You ask people what are they doing? They're working European time. They're working US time. They start at 3 p.m. They start at 7 p.m. and work. You're shifting, basically. You're shifting your clock. Of course, when you travel, you get jet lag. You don't sleep well. You have an irregular schedule. So our internal clock is completely in asynchrony. So what does it lead to? Look at the consequences of the misalignment. Immune dysfunction. That means you're most susceptible to infections and inflammation. cardiovascular risk, metabolic consequences, obesity, diabetes, insulin resistance, neurocognitive effects, mood disorders, impaired cognition, depression, worsening of asthma, COPD, exacerbations. So, if your clock gets disrupted, your body is completely misaligned. So, circadian misalignment is just not an inconvenience. It is a modifiable risk factor for many, many diseases. And that's what is my take-home message for you all today. If you all have understood just this much, you all have understood my talk. Okay? Now, this is a frequent traveler, somebody who travels from east to west, all the way up to Frisco or Vancouver from Mumbai, going through multiple zones. And then they say, oh God, I'm so exhausted. And why am I exhausted? Because my body is in another time, but my clock is elsewhere, right? And that is what is jet lag. So jet lag is a circadian rhythm sleep-wake disorder caused by rapid travel across time zones, especially more than 2 zones. So after a long-haul flight, the body clock is still aligned with the departure city, while the external world, whether it's the light, whether it's the meals, it's the working hours, has jumped to a new time zone. So until your master clock, your suprachiasmatic nucleus, re-entrains into the new schedule, the traveler is physiologically in the wrong zone. So what's the difference between jet lag and just travel fatigue? Travel fatigue is a general exhaustion that any long journey would have. You know, you haven't slept well, you're just sitting, you may be dehydrated, you may be stressed out. That resolves within 24 hours. While jet lag, by contrast, lasts until the body clock catches up. And roughly 1 day per time zone when you cross west. So I am going to Toronto actually in the middle of the week. So it's going to take me till Sunday at least before I set into Canada time, okay? And when I come back, it'll take me at least a week more because it takes 1.5 days on the way back, okay? So you've got to give your body that time and you've got to do the right things. So what are the symptoms of jet lag? And I think everybody knows, right? Everybody who's traveled knows that their sleep is disturbed. You go, you want to sleep in the middle of the day out there, you're tired, you're fragmented, you can't think easily, cognitive impairment, your reaction time is slow, your vigilance is less. And remember, you and I are not high performance individuals. That means we are not pilots, we are not surgeons, we are not athletes. These people who travel these time zones and are high performance people, they have to adjust pretty quickly. Their clocks have to adjust, right? We can take our time adjusting, but they have to. So you can get constipated, you can have diarrhea, you can have reduced appetite, your gut mobility goes for a toss, you have mood changes. It can trigger people with bipolar disorders, okay? Irritability, low mood. So these are all the symptoms of jet lag. So not all jet lag is the same. So what are the factors that cause jet lag to be more severe, okay? Direction of travel. If you're traveling, direction of travel, look at the center. If you're traveling eastward, okay, it's harder because you have lost time. Westward is easier because you're gaining time. Time zone difference, you don't notice so much when you're going couple of zones. So if you are to travel to Europe, or if you have traveled down maybe Australia, you don't feel it that much as you would feel when you go across to the US or Mexico or South America, right? And younger people obviously adjust better than older. Experience, so somebody who's a frequent traveler, who does it for business, once in 15 days, they get into, they come back within 3 days of a business travel, they have learned to adapt. Sleep and behavior, okay? What you do prior to you travel, what you do after you travel, affects how you, and how fit you are. Also, if you're a lark or an owl, do you all know what a lark and owl is? A lark is somebody who's great first thing in the morning. Me, okay? An owl is somebody who's very happy at night. They are the night people or the nighttime people. So the larks adapt more easily to the early schedules while the owls struggle with the early mornings. Yeah, so lark and owl. So how do you reduce the jet lag? I think that's so important, right, when we travel. So light therapy, like I said, is the strongest Zeitgeber. So eastward travel, if I'm traveling from San Francisco back to Bombay, I must seek the bright light in the morning when I reach my travel destination and avoid bright light early in the evening. So then it also depends on when your flight lands. If you land at 12 in the afternoon, you are in trouble, more trouble. If you land in the middle of the night, at least next morning you can get the light. Similarly, westward travel, because you need to delay the clock. You've gained time when you've gone west, right? So you have to stay awake and you have to seek the light in the afternoon, okay? Really expose yourself to the afternoon light so that then your clock can set easily, okay? Easier said and done. I'm landing at 9:30 a.m. How am I going to avoid the morning light? I don't know. I'll probably let you all know when I come back. I'll let Jayalakshmi know how I've come. So melatonin. Melatonin is a very good drug for jet lag, okay? It's both a chronobiotic, that means it can shift the clock, and it's a mild hypnotic. So basically you have to take it at target bedtime when you reach the new zone. So when I reach whatever I go, Toronto, Frisco, I must take melatonin in that evening, okay? When I reach there, and I continue it for 2 to 5 days. The dose is 0.5 milligram to 3 milligram. You can go up to 5 milligram also. At 5 milligrams, it becomes a little bit of a hypnotic. For eastward travel, in fact, the recommendation is you use a very small dose in the afternoon as you're traveling eastward, okay? And then you are able to set your clock better. Again, I'll tell you all when I come back what I'm going to do. Okay, sleep scheduling and phase shifting. This is seriously done by high-performance athletes and pilots and things like that. So, for example, since I'm traveling to Toronto, the recommendation is I sleep 2 hours later every night. I push my sleep schedule 3 to 4 days before I depart, okay? So that's sleep scheduling. Caffeine, early morning caffeine for people who do well with coffee, unlike me. Modafinil and Modalerts are drugs which are very prescription-based. So this is for people who really can't keep their eyes open and they've got businesses and they're just there for 2 or 3 days. You can give them that temporarily, to stay awake. Short-term hypnotics, I wouldn't recommend because it's risky to take short-term hypnotics. It can then cause serious sleep phase disorders, okay, once they come back. Yeah. So this gives it in a nutshell. What I said, light exposure, late afternoon westward, early morning in the eastward. Melatonin, not needed, small dose at destination bedtime, okay? And needed if you're traveling back east. Shift your bed hours 1 to 3 days before departure westward and advance your sleeping time as you travel eastwards. Caffeine, and it is going to take time to adapt. So don't try to be a hero or a heroine. And when is it not jet lag? We already talked about travel fatigue. Some patients may just get an environmental insomnia, which may last for a day or two. Okay, that goes away. Some of them can get hypoxic during travel. See, underlying other circadian rhythm, disorders are there. And like I said, it's a big talk, which I've not touched on. So you may have an underlying disorder, okay, which is a delayed sleep phase disorder, an advanced deep phase disorder, non-24-hour rhythm disorder. So these symptoms predate the travel and they persist very long after adaptation and should be investigated, and mood disorders, which is why I don't like to give zolpidem when people travel, because you never know when you can trigger a major depression or a bipolar disorder or an anxiety, okay? Pre-pro travel. And then, so this is what the high performance, a very crowded slide, but eventually what it means is, if you're a pilot, if you're an athlete, if you're in the military, and you have to adjust to time zones, you have to follow the principles. Shift the clock, light, timing matters, small daily adjustments, they are done, and they have to be done, yeah? And the most important thing, the pearl out here is, performance is maximized when the circadian rhythm and external environment are aligned. And the goal is not simply eliminating jet lag, it is to restore the physiology. And I end by saying that the future is in chronomedicine. So what is chronomedicine? We are going to have clock gene markers, which we are working on, wearable circadian monitoring. We already have our Apple watches and what know you and your aura and all, which gives us, some amount of what sleep that we have. Personalized chronotherapy, which is the right dose, right drug, right dose, right patient, right time, and AI-guided treatment. And medicine has always asked what to treat. The future will be also to ask when to treat. Thank you very much for your kind hearing.
Dr. Anuradha, you are always wonderful speaker. मैम जो बच्चे आधी आधी रात तक जागते हैं आजकल, 2-3 बजे रात से पहले कोई बच्चा सोता ही नहीं है, उनके लिए क्या कर सकते हैं? या जो जिनकी नाइट शिफ्ट्स है, कॉल सेंटर्स में नाइट शिफ्ट्स तो
Yeah, so that is a very good question. See, the ones who don't sleep till 2 and 3 in the morning, we really have to work hard to educate our youngsters, okay? And it's an effort, it's a community effort. As doctors, we must really take it upon us to talk about what we call sleep hygiene, right? Eating at the correct time, exercising at the correct time, and sleeping at the correct time, and these exposures. So shift workers is a completely different problem. Shift workers, that is why typically when they have night shifts, the next, they should, you start with a morning shift, then they should be moved into afternoon shift, and then night shift, and then given a few days off before they switch back into the cycle. That's the only way it works. There is no choice, because that's their livelihood, right? And we have a lot of people doing that. But it has to be aligned. Morning shift, afternoon shift, night shift. They have to do all the correct things at that point. Yeah? And I'm happy that you mentioned this. It's been our endeavor to actually talk about importance of just proper sleep, not just our generation, but the most important thing is the youngsters. And we have to start young. You're telling me, adults, young adults. How many of you have children, grandchildren out here who are young, school going? How many of those children are going to bed at 8 p.m. or 8:30 p.m.? Nobody. How many of them are not exposed to cell phones, iPads, mobiles? Small population. So it starts there, our education. And I've had the opportunity to address a few schools in South Mumbai where you will not believe if I've addressed parents of 4 to 8-year-olds and then the children themselves, okay, and subsequent till teens, okay, multiple shifts. And I've talked about sleep, and I've talked endlessly about sleep hygiene. And I have had 4-year-olds asking me this question of 5-year-olds, can I sit and watch television when I'm eating? Can I scroll my iPad? 5-year-olds asking me this question. How has it come to that? It is because the parents are giving it, right? You go anywhere, airport, station, bus stand, you find the child is sitting. Why? Because then the child is glued to it. the parents can do what they want to do, right? So that's where the education has to start. Yeah, thank you.
Thank you, ma'am, for the wonderful oration and the presentation. I would like to call Dr. Pranali Patil for the token of appreciations for the speaker and the chairpersons. May I request Dr. Jayalakshmi TK, Dr. Santesh Kaushik, Dr. Anuradha Shah, Dr. Kiran Marthak, Dr. Bhumika Madhav, and Dr. Arjun Ramaswamy, along with Dr. Girish Nair sir, to kindly come up for the ceremonial lamp lighting. Our next session is on reading compliance reports. It will be presented by our beloved Dr. Jayalakshmi TK ma'am, the chairpersons for the event, Dr. Kiran Marthak, Dr. Arjun Ramaswamy. I would like to call up Arjun sir and Kiran sir in the stage along with Jay ma'am. Dr. Kiran Marthak is in practice for more than 5 decades. Very rich experience in clinical research, holding senior positions in clinical research departments in MNCS. Currently member of the board of director in Veda Life Sciences and International Contract Research Organization with a presence in 20 countries. He is also chairman of 2 ethics committee and a member of Pharma and Biotech committee in CIA. He is Secretary of Western Chapter of American College of Chest Physicians and Advisory Committee members of South Asia Chapter of American College of Clinical Pharmacology. Dr. Arjun Ramaswamy is the leading senior consultant in the Department of Pulmonology, Apollo Navi, Mumbai. I would request Jay ma'am to please take the podium.
Good morning, everybody. I'm Dr. Kiran Marthak. I have a colleague here, Dr. Arjun. And I have a pleasure of introducing our Dr. Jaya Lakshmi, who is not only esteemed speaker, but a very good academician as such. As we all know, she is a professor as a chest medicine, DETRD diploma in environment, TB and chest disease. And she is also a diploma holder in pediatric sleep medicine in association with the University of Colorado. She is a consultant in pulmonary medicine at Apollo Hospital, Navi, Mumbai. And she comes with a very rich experience of more than 27 years in pulmonology and thoracoscopy. Post her MD, she completed the European Respiratory Medicine MRCP1 as well as MRCP2. And she has a special interest in COPD, bronchial asthma and allergy, TB and MDR TB and bronchoscopy. She pollution affected patients with asthma, COPD and hypersensitivity pneumonitis. Yes, awards and associates, just to give an examples like Dr. C.P. Mohanty Award and Gold Medal for standing first in DETRD, Hermes European Diplomat Award, Honorary Secretary of the Indian Association for Bronchoscopy, currently Honorary Treasurer of the Indian Association for Bronchology, Honorary Secretary in the Indian Association of Bronchology, and she is awarded Fellowship of American College of Chest Physicians. And she is also a very active member of the Western India chapter of American College of Chest Physicians. So with that, ladies and gentlemen, I have a pleasure of presenting to you Dr. Jaya Lakshmi. Thank you, madam.
Thank you. Thank you, Dr. Kiran, for very kind introduction. So today I will be talking on very simple thing, but very important when you're seeing sleep patients who are on CPAP machine. So you yourself may have recommended CPAP therapy for your patients, or somebody of your relatives may be using it. So the most important thing when the patient comes for follow-up is something which is called as a compliance report, which is a very simple thing, but it gives an information about what therapy the patient is actually taking, how much the patient is really adherent to the therapy, and looking at it gives you a guidance as to what problems the patient may be facing and how to correct these problems. So it's a very simple thing which we can do in our OPD, which will vastly increase the quality of our treatment as well as the quality of the patient's night sleep. So as we know, sleep apnea is hugely prevalent, and in India, the prevalence is as much as in the countries like USA, more than in France, Germany, Russia, Japan, just because of the obesity pandemic which is going on currently in our country. percentage of the patients with AHI more than 5 is 52 million. One of the studies, systematic review and meta-analysis of the prevalence of obstructive sleep apnea was conducted in the Indian patients by Dr. Tejas Suri and team. And it found that approximately 104 million Indians of working age suffer from OSA, and 47 million have moderate to severe OSA. So it's a major public health problem and important implications for global health and disease. So coming to the topic, what does a compliance report look like? So this is a compliance report of a patient age 63. So he has been using the machine, and you can see the number of usage days. So you can see here, where I put the marker, that the patient has used it from 1/5/26 to 31/5/26. So this is a 1-month report. So here the usage days is 31 out of 31. So you can see that this patient has an excellent compliance in terms of number of days used. And out of which more than 4 hours uses, again 31 days. So this patient has an excellent compliance again of using for more than 4 hours. So what is the significance of using for more than 4 hours? We will come to later. And so this is the hourly usage, the average usage per day. So around 8 hours the patient has used the machine, which is very ideal. Although we say minimum 4 hours, the correct minimum time is 6 to 8 hours. The more, if you use it throughout the sleep period, it becomes much more beneficial in terms of various health paradigms, that is the blood pressure, cardiovascular risk profile, stroke risk profile. All these things improve only when there is an adequate compliance. So various studies have been carried out in patients who have used CPAP, and they have not found very good result in improving cardiovascular morbidity or prevention of stroke. Why? Because the usage was less than 4 hours. So if they saw the subset of patients who have used it for more than 4 hours or more than 6 hours, they found an improvement in the risk parameters for developing stroke, or improvement in hypertension, or prevention in the cardiovascular risk factors. So this point is very important, that they have to use it for sufficient number of hours. Otherwise, just buying the CPAP machine and keeping it at home is of no use for the patient. So here you also are able to see the mode, what the patient has taken, the APAP. You can see the minimum pressure 6 and the maximum pressure 20. So this patient has been set on an auto CPAP mode, where there is a minimum pressure and a maximum pressure, and there is something called as an EPR, which is an expiratory pressure release. So when the patient is using this machine, there is a air which gets built up. So when you put it on an EPR function, there is less choking or feeling of claustrophobia for the patient, because there is less air buildup in the mask. So this is also one setting which you have to pay attention to. Generally we set it at 2 to 3. So this patient has an EPR setting at 3. So this is the therapy pressure. You can also see what median pressure the patient has received. So he's received 11.9 pressure, and the 95th percentile pressure is 15.3, maximum pressure gone up to is 16.9. So your setting of 6 and 20 is okay. So if the patient continues to be like this, you can actually lower down the maximum pressure. So this patient has a minimum pressure setting 6 and maximum pressure setting of 20. So by looking at this compliance report and seeing that the patient maximum pressure is 16 and 95th percentile is 15, patient may be more comfortable if you set the upper pressure at 17 or 16, so that there will not be sudden increase in pressure up to 20, which the patient does not need anyway. So this is how you modify the auto CPAP setting based on the compliance report. So you can actually use it instead of doing a titration study. So often we have to call the patients in the lab for doing a titration study. Expensive, patient may not want to come back for a repeat sitting in the sleep lab for a titration study. So instead of that, what we can do is, we give the auto CPAP and tell them we set it at minimum 4, maximum 20 pressure. So all the auto CPAPs will have 40 and 4 and 20 pressure. So minimum is 4, maximum, you set it like that and give it to the patient and see the compliance report. Like this patient has come back after 1 month with the compliance report. So in the compliance report, you see what has been the median pressure required, what has been the maximum pressure required, what has been the average pressure required. So if the average pressure or maximum pressure 95th percentile is 12, the patient does not need to set a maximum of 20. So you can set the limits accordingly. You can set the lower limit at say 12 minus 2, that is 10. You can set the upper limit at 14. So the patient gets a relatively constant pressure through the night, because the best type of CPAP is where you set a correct pressure for the patient.
Auto CPAP is not really the correct therapy mode for a patient. Auto CPAP was initially designed to come to know as to what pressure. It's actually meant for the titration, to see how much pressure the patient requires. So this is the compliance. So you can see how this, you can see how in this picture, you can see the usage number of hours. It's all green. So the green bars are important. So if it's green, it means the patient has taken more than 4 hours every night. So this is usage. So this is every night bar. So each one is green, and this is the line which is 4 hours. So the patient has crossed 4 hours every day, and hence it's a normal. So now we come to another thing which we are seeing in the compliance report is the leak. So leak should be less than 24 liters per minute for this machine. The leak recommendation varies per mask per machine. But for this ResMed machine, it will be 24 liters per minute. This will be less than that is the acceptable leak. So this is in yellow, and some parts have come above the acceptable leak level for this patient. So whenever there is a leak, what we have to see is whether the mask sizing is okay, whether the mask fitting is okay, whether the patient needs any other type of mask. So there are 3 type of masks typically. We have a nasal pillow mask, a nasal mask, and an oronasal mask. So whenever there is a leak which is going above the acceptable limit, we need to check the mask sizes and the mask fitting. And this is the pressure. As we saw the pressure in the previous, you can see in this graph also, you can see the pressures which the patient has received through each night. And this is the apnea-hypopnea index. Yeah, you can see it clearly there. So the apnea-hypopnea index is well within acceptable limits. It's coming less than 5. So throughout, except for some nights when it has crossed more, probably because of the leak, the apnea-hypopnea index has gone high in few of the nights. So these are the corrections which you can make by seeing the compliance report. So now this is for another patient. So you can see for this patient how he has used it for more than 4 hours, only 9 days, only 29%. And less than 4 hours is 26%, and remaining days he has not used only 17/31. So the patient may tell you, I have been using the machine, but it's of no use. You should see the compliance report. So with the compliance report, you come to know actually how much the patient has used. And see the average usage is only 2 hours, 22 minutes. And the days used is 4 hours on the days which are used, and total days is 2 hours. So why this is important is, in the Western countries, they have an insurance which gives the machine. So the insurance will sanction the machine or continue use of the machine only if they've used it for more than 4 hours per night for more than 70% of the nights. Still, it is not sufficient to correct all the parameters like hypertension, prevention of stroke, prevention of cardiovascular risk factors, but at least that much minimum is required for as per the insurance. So here you can see again, you have the mode which is auto set, minimum pressure, maximum pressure. We have set at 4 and 10 because we had done the titration study for this patient. We know he does not need more than 10, so we have set it at upper 10. The EPR is only set to ramp. So there is something called as a ramp, where you can slowly increase the pressure. So the patient, although you have set the pressure at say 12, as soon as the patient puts the mask, the machine will not give 12. If you set the ramp at 15 minutes, it will take 15 minutes for the machine to go up to that pressure. Okay, so now you also understand when you set the ramp that the patient should not take off the mask in between. If the patient takes off the mask 5 times, each time the machine has to go up the ramp and then only it will reach the required pressure. So often what happens in the night is patients tend to take out the mask. So when they take out the mask, the pressure immediately drops to 0. And then when they keep it on again, the ramp function is functioning. So the pressure slowly will have to increase. So these patients are not getting optimum pressure for their CPAP, and hence their sleep apnea will not be well corrected if they are repeatedly uncomfortable with the mask, or they are removing the mask, or even if they are repeatedly going for a bathroom, so then they have to again break. So here also we can have a problem. So here again you can see that the pressure is around median of 7 only was required, 95th percentile was 8.9, so our setting is okay. So patient is requiring only 8.9, so we have set it at 10, so that is fine. Again the leaks is also okay, only 17.9, we can go up to 24. Events per hour is also okay. So when the patient uses the machine, everything is fine. But the basic problem is the compliance, that he has not. So for him, you have to do the guidance, do the counseling, see why he is not using, explain the importance of using. So So this is showing the, so if you see the graph, just don't look at the numbers. If you only look at the graph, you can see. So these are the greens where he has used more than 4 hours. These are the reds where he has not used more than 4 hours. Leak is acceptable except for 1 day. Pressure has not gone beyond 8, 9, which is fine. AHI also is fine on the days when he has used the machine. So we can explain to the patient the machine is working fine, everything is okay. You have to just start using the machine and increase the duration of hours of the machine. So you have, so what do you do? Once you do, commonly you will get a patient, you may have advised sleep study, or patient comes with a sleep study report. Nowadays many people know that sleep study can be done quite easily. People come home and do the sleep study. They will order their own sleep study and come home with the sleep study report. So when they come with the sleep study report, you have to discuss with the patient that this is what is positive. So usually AHI, you see the AHI. If it is less than 5, it's normal. 5 to 15 is mild sleep apnea. 15 to 30 is moderate apnea. And more than 30 is severe apnea. So you explain to them, but see everything in the report. And accordingly, you advise the patient to start using the CPAP. So I will not go into the report. We'll stick to the compliance of the CPAP. Explain the pathophysiology, explain the consequences of untreated OSA, give the treatment options, and see whether any comorbid disorders are there, that is depression, insomnia, pain, narcolepsy. So we need to first confirm the diagnosis. If there are so patient will ask, do I have to use a CPAP? Cannot I use some alternative treatment? Because people have the impression, and it may be justified also, that we have to use a machine while sleeping, it's cumbersome. When I'm traveling, it's difficult to travel and carry it all the time. But usually for patients who are snorers, the family will support hugely because the snoring sound goes away, so everybody is relaxed, patient is sleeping well, patient is alert. And especially patients who have a lot of sleepiness, they are very compliant to this machine. We'll go into that. So basically, if there is snoring, you treat nasal congestion, advise the lateral position. Some oral appliances are also there which can be used, advise weight loss. And so depending on whether it is mild, moderate or severe. So for moderate, generally the PAP therapy works the best. And oral appliances can be used for those for whom the PAP therapy is not useful. That is, people who are not able to tolerate the PAP therapy. For them, surgery or oral appliances can be recommended. But the first and gold standard for treatment of OSA at present remains the CPAP therapy. Weight loss, you can advise positional therapy. Oxygen supplementation is not used as a treatment for OSA. If the patient has desaturation and he has OSA, correct the OSA first and see if the desaturation is going away. If it is going away with that, then there is no need for giving any supplemental oxygen therapy. Nasal steroids may improve if there is concurrent rhinitis only. Modafinil can be used in certain patients who are having sleepiness, residual sleepiness, means even after using CPAP properly and having a good compliance, still they are having sleepiness. For them, you can advise the modafinil for remaining awake at night. And we don't recommend generally SSRIs or protriptyline for just treatment of OSA. So now we come to the compliance. So compliance can be subjective. Like patient is telling you that he has slept, is using the machine well. And there is something called as an Epworth sleepiness score, where you see how sleepy the patient is in the daytime, whether he's alert while speaking, while driving, while sitting in the car, while just sitting in the afternoon after lunch. So this gives you an Epworth sleepiness score. Then there are self-validated scores like FOSQ. You can do a phone call and ask this. So many in the Western countries, they have this, once the patient has been recommended the CPAP, they will monitor by using a phone call. So the first 1 week is very critical. So they will call the patient the next day. Have you used the machine in the night? Was it okay? What problems did you face? Call again after a week. So if we can do that, this is very good because it can improve the compliance. So this has to be set in the system where the patient is getting proper monitoring by means of phone calls. Objective compliance you see by number of hours and by the compliance report. So this compliance report is and effective compliance is time spent at the prescribed effective pressure in the night. So what is the factors predicting a good adherence for the patient? Most important factor is whether a patient is sleepy. If the patient has a lot of sleepiness in the daytime, they are very likely to use the machine because they feel awake and alert. They are happy. Then they use the machine no matter what. So you saw that patient of ours, the first patient who had 100% compliance. He's so happy. He works in finance field and he says, I'm alert for the first time after starting to use the machine. So they have a huge compliance. If there is a higher AHI, the apnea-hypopnea index is very high, then also the patient will tend to have a better compliance. If they are perceiving that they are having a benefit, then they will use. If they have been early monitored, like if they have an early, first 1 week, first 1 month is very important. If the patient did not use it for the first 1 week properly, it's very unlikely he will start using it at a later date, unless you really work hard with the patient and do counseling. Spouse referred patients, like some patients don't have any problem, but their spouse is referred them because they are snoring at night and the snoring is disturbing their sleep. These have the least adherence, they are least bothered. So they say, I am sleeping well, what's the problem? So they are having a very poor adherence. Or if they are not sleepy, they don't have symptoms. They are snoring, they are obese, but they are not having symptoms, they are awake. So such patients are also having a poor adherence, even though they may have a high AHI. So more than AHI, it's the sleepiness or the symptoms of the patient which provoke them to seek treatment. And also, if the patient is feeling that we are not having any effect of the treatment, so they are starting the CPAP and they feel they are still sleepy or they are not comfortable and they are not having any effect of the treatment, then they will be less adherent. So you see the percentage of days, average use, nightly use, percentage more than 4 hours. So one study was done which showed that only 46% of the patients who have been prescribed CPAP actually use for more than 4 hours at night for more than 70% of the night. So the adherence in patients who have been followed up in the study, so this patients is only 46%. So you can imagine in the general population how much it might be. So how much adherence is enough? So if you see this, the objective adherence for a period of 1 month, more than 4 hours of use for more than 70%. And the treating physician documents in a face-to-face meeting that the patient is benefiting from PAP treatment. Then only Medicare guidelines show that they will be reimbursed. We don't have Medicare guidelines, we don't have reimbursement, but still this is the minimum what has to be there for the patient. So these are the parameters which you see, which we have already gone through. And this is another sample compliance report. Again, you can see that you can see more than 4 hours usage for this patient is 26 days, less than 4 hours is 0 days. Only 1 day the patient has not used, all other days the patient has used. Whether there was chain stroke respiration. Here even the saturation has been checked. So time with saturation less than 88 is 18 minutes. This saturation you will get only if you are attaching a saturation probe along with the machine. Then you have the median pressure, the 95th percentile pressure. So this is important because sometimes what we do, we set the CPAP or the CPAP pressures is continuously hitting. Like suppose you have set the pressure. So here you can see the, like in the earlier range, we had the pressure which we were able to see here. So for this patient, we are able to see the pressure. So sometimes what happens, we set the pressure at 10, but every time in each night, the patient is hitting 10 and the symptoms are still there. And AHI may be high. So that means we have to increase the set pressure. If the patient is hitting the pressure every day, it means the patient may require more pressure. We don't know. So we have to set it at a higher pressure and see how much is the optimal pressure which is required. So that is also an information which you will get from the compliance report. So here again you can see the saturation, you can see the AHI, and in this AHI you can also see up there is a lighter part which is the apnea index, and the dark purple is the hypopnea index. So you can see the total apnea plus hypopnea, and you can also see how much apneas are there and how much hypopneas are there. So much detailed report you get from the here. So here again you are able to see the leak. So you are having the top of the bar which is 95th percentile leak, the dotted line is the leak threshold. And so we have a set threshold which is 24, and this horizontal line indicates the median leak. So you get the information about the leak. So now these patients, this is a patient who is having a BiPAP. So in a BiPAP again you have the humidifier setting is also seen, the BiPAP AVAP's pressure you are able to see. You see the average pressures which is going on in IPAP as well as EPAP, and the pressure support which is seen. Which is IPAP minus EPAP gives you the pressure support. So when a patient is on AVAPS mode or on a BiPAP mode, also you get a compliance report which exactly shows you how much pressure support patient got, how much tidal volume patient generated. So all this information you can get from the, so you can see the average tidal volume is 786. So this you are getting from a report which the patient is bringing after a month. So this is very useful. And here the average IPAP, the average EPAP. So you can see with each date how much the apnea-hypopnea index has been for each night. The IPAP 90% of the time how much it was, EPAP 90% of the time how much it was. So all this, leaking, whether it was there, whether there was a large leak, how much percentage of the time patient had a large leak. So this will be the chart which shows you each night how much the patient has used, how much the patient has not used in these nights. So at a glance you get an idea as to what has been the compliance. So you see the compliance, leaks, volumes, pressures. So you get all these things. So it's almost like the ventilator data. Like when you're seeing the ventilator, you're seeing so much, no? Similar information you're getting when you're seeing the compliance report with the patient who's on auto BiPAP or auto CPAP. So take-home message from my talk is that we should ask the patient or the supplier who has given the machine to generate the compliance report for the patient. When they come for follow-up, they should come with the compliance report. Can be on their phone, but they have to show it to you. So how can you improve adherence? You educate well, involve the spouse, involve the family, see whether any mask problems are there, see whether any early intervention need to be done for side effect concerns. Generally, patient complain of bloating, nasal stuffiness, the mask can cause irritation in the bridge of the nose. So these things can be easily addressed and corrected when you are. So it's important, it's not that you just advise the patient CPAP and then tell them, okay, now you manage. Call them after 1 week, call them after 1 month, call them after 3 months, and see the compliance report at each time so that we know that the patient is using. Okay? And ask about the symptoms, whether they are feeling sleepy or not. Ask them whether they are feeling that they are benefiting with the treatment or not. Ask whether they are anxious about the treatment. Sometimes we can call them during the day, ask them to use the CPAP in the day, fit the mask, and then see how they are experiencing. So then that reduces the fear. Otherwise, using a CPAP mask and sleeping is always a fear-inducing process for a patient. So a little bit about the common side effects which we can get. Air leaks can lead to conjunctivitis, discomfort, noise, nasal stuffiness, skin breakdown can be there. So for air leaks, you do a proper mask fitting. Maybe you may need to change the mask, different type of mask. And for skin breakdown, don't over tighten. Nasal prong or pillows will avoid skin breakdown. Mouth leaks and mouth dryness, you treat the nasal congestion. Sometimes nasal sprays can help. Saline nasal sprays can help. Sometimes for mouth breathing, you can use a chin strap. So along with the nasal mask, you can get a chin strap, which just allows the patient to keep the mouth closed. Mask claustrophobia can be avoided by using nasal pillow mask. And unintentional mask removal can be avoided by giving a low pressure alarm. So if the patient has removed the mask, the machine will give an alarm. So just few questions to test the understanding. So which of the following is the most predictive of good PAP adherence? So one, if the ESS is 16, ESS gives an idea of the sleepiness of the patient. If it is 16, it means patient is more sleepy in the daytime. Or if the treatment prescription has 8 versus 16, means less pressure CPAP versus higher pressure CPAP. Spouse referral, and patient has done a full night PAP titration. Does it predict that the patient will have a good adherence? So among these 4, which is the most likely for patient to have a good adherence? A. So A is because the patient is sleepy. So we mentioned that where patient more symptomatic, he is more likely. Higher pressures does reduce adherence, but it is not a major predictor. Similarly, using a full night titration is also not a great predictor for having a better adherence. Spouse referral, we know, is a poor predictor. So another is patient is treated with CPAP of 12, has severe bloating. Pressure is reduced to 10, but bloating still continues, and patient wife is noticing mild snoring. So because bloating was there, you have reduced the pressure, but it became that the patient started snoring, means the OSA is not getting corrected. So that was not a good strategy. So what will you do for this patient? So you have option of further reducing CPAP, which you will not do because for reducing little has not helped. You can put the patient on auto CPAP and then see, or you can put the patient on BiPAP with the same pressure or with a lower pressure. So what would you do? So in such patients, you can use an auto CPAP because with an auto CPAP, much of the night patient may not require a high pressure. So you have avoided those times of high pressure. And some part of the night, the patient may require a higher pressure when he's supine or when, so the total high pressure time reduces. So the bloating symptoms can reduce. And then you can see what is the optimum pressure. Failing that, you can put the patient on BiPAP because with BiPAP, the expiratory pressure reduces. So the total pressure which the patient is receiving, it goes down. So these are the options. So one patient has a severe daytime sleepiness in spite of adhering to his CPAP. So his AHI was 2, which was okay, with 10 centimeter and supine, no snoring, everything is fine. But he's still sleepy. So what will you do for this patient? So these are the options. A sleep extension, or you do a repeat polysomnography, or you add some medications, or you again see the titration. So in this group, it is okay to give a modafinil treatment or sleep extension. So you are giving, patient is sleeping 6 hours. Maybe 6 hours is not enough. Optimal sleep is 6 to 8 hours. This patient may require 8 hours of sleep. So ask the patient to sleep for a longer period of time and then see if the symptoms are improving. Failing which, you can try the modafinil. So yeah, that's. Thank you.
Thank you so much, ma'am, for that elaborative and wonderful talk, for clearly explaining to all pulmonologists how to go about a compliance report and how to take care of a patient completely after your first review in the clinic. I don't think there is any much explanation that is required. She has beautifully covered every aspect. So we can.
Thank you. Thank you all for patient listening.
I would like to request Dr. Ravindranath Sahai to felicitate our speaker and the chairpersons. Sangeeta, okay. Sangeeta ma'am, please come up on the stage for the felicitation as well. Next up, our presentation is on heart disease and OSA. The speaker is Dr. Shantesh Kaushik. The chairpersons for the event, Dr. Brajesh Kumar Kunwar and Dr. Mahesh Khogre. Dr. Mahesh Khogre, Consultant Interventional Cardiologist at Apollo Hospitals, Navi, Mumbai. Dr. Khogre holds an MBBS and MD in Internal Medicine and DM in Cardiology. With over 13 years of experience in cardiology, he has established himself as an expert in interventional cardiology with complex coronary interventions. Dr. Brajesh Kumar Kunwar is Senior Interventional Cardiologist at Apollo Hospitals, Navi, Mumbai. Dr. Kunwar has over 15 years of experience in the field of cardiology. He has completed his MBBS and MD in Internal Medicine and DM in Cardiology from Christian Medical College, Vellore. He is also a Fellow of the European Society of Cardiology and the Society for Cardiovascular Angiography and Interventions. Santesh sir, can you please take the podium?
Yeah. Morning, everyone. I know it's a bit. Sorry? Oh, okay.
It doesn't need any introduction. It's my privilege to welcome Dr. Shantesh Kaushik, sir, very eminent and senior-most cardiothoracic and vascular surgeon. He has got more than 28 years experience, not only in bypass surgeries, but total artery revascularization, lung surgeries, aortic surgeries, and all sort of related vascular surgeries. So he is trained at Royal Melbourne Centre at Australia and Boston Clinic in United States. Please join me in welcoming Dr. Shantesh Kaushik. Thank you.
For the night owls, coming on a Sunday morning before 11 itself is taxing. So I have kept my talk short and sweet. Everyone is using all these hi-fi terms, Greek and Latin, for a lot of the general people. I am also among the general people because, sleep medicine specialists are a different group altogether. So, they are at a higher pedestal. So I have simplified the terms and I'm finishing my talk fast. Okay, so I'm not going to spend too much time. Now, that's why I've started off with physiology of sleep, because last time when we had the sleep meet, the physiology was considered, but this time people may not even know the terms. So, what is the average sleep duration? Anuradha madam covered part of it, but at least 7 hours. And as we age, in infants it can be even 14, 16 hours, and go up in 60 plus, it is even less. Okay, so it can be even 4 or 5 hours. So, stages of sleep. What is polysomnography? Now, many people would not even know that, unless at least I didn't know it. So, it's a pattern of the EEG, then the measurement of the eye movement with the electrooculogram, and the surface EMG, which is measured on the chin, legs, and neck. So, and continuous recording of these electrophysiologic parameters defines sleep and wakefulness in polysomnography. Now, sleep is divided into the non-REM component and the REM component. The non-REM component is within the first hour of sleep. Usually, it comprises 75% of the sleep cycle. There are 3 stages, N1, N2, and N3, and basically they are classified based on the increasing arousal threshold and slowing of the cortical EEG. N1 and N2 comprise about 50 to 60%, and N3, that is the slow wave sleep. This is actually the real deep sleep. It is usually in the first third of the night and comprises about 15 to 25% of sleep. Then the REM component, that is usually in the second hour of sleep, comprises 20 to 25% of total sleep. The EEG is similar to N1, and the electrooculogram is what shows the rapid eye movements in flurries and bursts, and the EMG is absent in nearly all skeletal muscles except the respiratory muscles, reflecting brain stem mediated active muscle paralysis. So this is the ultradian sleep cycle, alternate cycles of REM and non-REM sleep every 90 to 120 minutes. Now the most important, actually that is a very important point, that the dreams and the important part of the sleep is towards the end of the sleep cycle. So what in Marathi is called sakhar zop, so that last part of the sleep is very important. Now, age and sleep. N3 is most prominent in childhood and may even be absent in older adults. So, not having an N3 is common in older adults. It's nothing to be worried about. Aging increases the fragmentation of the non-REM component with increased frequency of awakenings rather than decreased ability to fall back asleep. So you may wake up more times, but you should be able to fall back asleep. So that will still be part of the normal aging process. So now we come to the sleep disorders. Now sleep-related disorders may be prevalent in up to 35 to 40% of the population. Unfortunately, there is no clear didactic study, so multiple studies give different incidences, and actually now the incidence may vary with the obesity level in the population. So in the US, as obesity is falling, sleep disorders are also decreasing. Now, inadequate sleep contributes physiologically to multiple pathologies, as physiology of sleep is very important for multiple functionings of the human body. So I'll just briefly cover each one. Is glucose intolerance and development of diabetes, obesity and metabolic syndrome, impaired immune response with increased susceptibility to infection, accelerated atherosclerosis and increased heart disease risk, cognitive impairment and Alzheimer's disease, hypertension and stroke. Like the amyloid plaques which develop, if you have a good sleep, they can be cleared. The lymphatic network of the brain is intact, but when you have inadequate sleep, then the plaque development worsens, and that's how Alzheimer's is potentiated. Then sleep duration or quality was a newer lifestyle recommendation for heart health, only introduced as late as 2018 in the American and the European guidelines, and along with pollution. Pollution also came into the guidelines as of 2018-19. So deterioration in sleep duration or quality causes increased nocturnal blood pressure. That is now very clearly defined, and the onset of or poor control of hypertension is directly correlated with sleep duration or quality. And ambulatory blood pressure monitoring, the 24 hours blood pressure monitoring is a must to get the proper diagnosis. Normally physiologically you get a nocturnal dip of about 10 to 20% of your blood pressure during deep sleep. And this is a physiological response which is the only time the heart and the vascular system gets time to rest. So if you do not get this important rest, then obviously the machine which is working, even your cell phone has to be charged. If your heart and vascular system is not charged during sleep, obviously it's going to cause problems. So lowest values of BP occur during REM sleep due to reduced sympathetic output, recumbency, and active brainstem mediated muscle relaxation. And we have the non-dippers in whom the nocturnal dip is less than 10%, and it is associated with heart disease. So what about the sleep and the heart duration? Less than or equal to 5 hours of sleep increases the frequency of hypertension and all heart diseases. Now, what you have to understand, it is quite age related. Okay, middle age group is the most susceptible. So have the highest association between short sleep duration and hypertension, and some studies have not shown any association over the age of 60 years. Now, sleep heart study, longer the sleep duration, also more than 9 hours sleep also increases hypertension. So it is the optimum sleep level, which is about 7 hours. Even excess or less, both are harmful. Adolescents and young adults 18 to 44 sleeping less than 7 hours also were associated with a higher incidence of hypertension. Depression and psychosocial factors. Now, depression and psychosocial factors have a bigger role in women, and along with less than 5 hours of sleep. And finally, what if you are sleeping less throughout the week and can only manage catch-up sleep on a Sunday where you are giving a talk? So at that stage, the Korean study has looked at this. They studied almost 10,000 patients, and they found that the catch-up sleep also reduced. Even 1 hour of catch-up sleep reduced your incidence of hypertension. So this is a pictorial graphic. As you can see, decreased sleep duration and quality cause OSA, insomnia, snoring, stress, circadian rhythm, sleep disorders. All these ultimately result in stimulation of the sympathetic activity, lead to non-dipping, as I said, disruption of endothelial function, hypothalamic pituitary adrenal axis, and hypoxemia. So as Dr. Anuradha had already alluded, night shift sleep disorder increases cardiovascular event risk by 17%, with a 7.1% incremental risk every 5 years. This was the largest study by Torcotti. They covered almost 30,000 patients. Then Karnik et al. Found that prevalence of insomnia in 700 hypertension patients, this is an Indian study, almost half had insomnia, and 75% cases of insomnia were underdiagnosed with decreased daytime well-being and functioning. So all your patients of hypertension, please check about their sleep. They may have had recently a relative who has died, because of which they're not sleeping. So there may be a depression underlying. So it's not just, you just don't give 4 drugs for hypertension. You look at the other factors involved. Then restless leg syndrome or the Willis-Ekbom disease, the periodic limb movements of sleep leads to increased sympathetic activity during sleep, and hypertension also. It was corroborated in the nurses' health study. And finally, again, melatonin, madam has covered it extensively. Melatonin intake over a 3-week period improves sleep quality. It takes at least 3 weeks of regular melatonin use to actually improve your sleep quality and can reduce hypertension. Unfortunately, I could not find a single study where melatonin has been studied in resistant hypertension. So we don't have a correlate, and that study actually needs to be done. Now we come to the main part of my talk, the OSA and the heart. OSA is an independent risk factor for hypertension and accelerated atherosclerosis and affects 15 to 24% of adults. The severity of OSA, as Dr. Jayalakshmi showed us, that apnea-hypopnea index should be more than 15. That is severe OSA. So India was estimated to have 2.9 crore OSA patients in 2021. Today it is more than 10 crore because obviously obesity has also increased. Now the pathophysiology of OSA. How does OSA cause a problem? So transient hypoxia during a sleep apnea episode, sudden arousal from sleep with a brief period of hyperventilation, release of catecholamines with increased BP and heart rate. So actually the time when the heart and the vascular system should be resting, you are doing exactly the opposite. You are releasing catecholamines, which lead to, when this happens chronically, it leads to oxidative stress and a systemic inflammation. As you know, the CANTOS trial has shown us that inflammation is an important component of atherosclerosis. Then endothelial dysfunction with increased atherosclerosis risk and hypertension is what ensues. Finally, there are other mechanisms also of OSA. Increased fluid volume in pregnancy and end-stage renal disease causes upper airway edema, reduced lung volume with reduced reduced upper airway size. Then stimulation of the renin-angiotensin system with hyperaldosteronism. And finally, the very brainstem reset occurs. So the resting sympathetic activity is itself upgraded. So there is a continuously higher sympathetic discharge. So this has been confirmed with PET screening trials. And hypertension is diagnosed in women many years prior to OSA. So though the OSA was the cause, they are diagnosed as hypertensives, and it takes many years, especially for women, because there's under-screening of OSA in women. So we have to always realize that a woman hypertensive, we should definitely check for OSA. Then hypertensive disorders of pregnancy and OSA strongly correlate with preeclampsia, which is more common with OSA in early and mid-term pregnancy. Finally, the last slide for OSA, hypertension control even with 4 drugs may be difficult if the OSA remains untreated. So always rule out OSA in resistant hypertension. Then continuous airway pressure, positive airway pressure, as madam showed, reduces hypertension medication and reverses the sympathetic overactivity as well as endothelial dysfunction. CPAP reduces both systolic and diastolic blood pressure, and mandibular advancement devices also show a similar reduction in blood pressure as CPAP. So whatever controls the OSA controls the blood pressure too. So conclusions, sleep disorders with OSA are a major public health issue today and an independent risk factor of heart disease. Hypertension and OSA have a strong correlation, and OSA should always be ruled out in every case of hypertension, more so in resistant or uncontrolled hypertension. The Upanishads talk of 4 states of consciousness. The waking state, which I hope everyone is just now. The dream sleep state. The dreamless deep sleep, that is the true deep sleep. And if you are an accomplished yogi, then you can achieve turiya. That is a brain state similar, alpha waves, when you are fully conscious. Actually, you are hyper-conscious at that stage. And finally, the culmination of Patanjali's Ashtanga Yoga pathway, Samadhi, which is beyond consciousness or superconsciousness, the godlike state. So may we all at least experience Turiya during this lifetime. I end on this note. Thank you. There is no negative correlate. It's just how your physiology is distributed. There are people who sleep lesser hours at night and sleep in the afternoon. So that's how your body, what your body is used to. Yeah. Yeah.
So, I'll just have a comment. Excellent talk, sir. 2 things to give an opinion on. One is there is a very common conception that, there's a very common conception that only obese people have OSA. That is the reason we have been attending sometimes, references for heart failure. And we do see a patients in OPD treated for a heart failure. You find everything, you find ARNI, you find all new drugs. Everything is there for the patients of heart failure. Patient is on atrial fibrillation, Codron is there, patient is NOAC is there, but no one has evaluated the OSA and probably the root cause. So many a time the treatment of OSA is sufficient to treat the patient of, heart failure. So I think in a checklist of a heart failure patients, it's important that I think we should always put OSA as number 1 or number 2 negative. Make sure that before you evaluate, you need to. Another thing is, I'm not sure, this is my experience, that snoring is not always associated with OSA. I mean, our negative history of, does your husband snore? And the wife says, nahi, snoring nahi karte hain. So when you advise a sleep study, people are not willing for that. But sometimes I've realized that the sleep study OSA comes so positive, even though patients, the wife does not report. Probably she's also snoring and she doesn't want to, she's also snoring, husband is also snoring. So probably they don't want to tell each other this thing. Yeah.
Just very important here, I rely more on excessive daytime sleepiness, low energy levels as the sort of litmus test, not snoring. Of course, if they're snoring, definitely. But I just ask them, are you okay? Energy levels okay during the day? If not, I send them for a sleep study.
Yeah. One more comment, idiopathic atrial fibrillation. So that is so important. So when I normally talk, I tell people about AF. If you don't find a cause for AF, please look for OSA, because I think that's the commonest presentation, idiopathic AF.
So, as Dr. Girish rightly mentioned about daytime somnolence, so the thing is, if you ask this, तो कभी-कभी what I get a response from wife is, ये तो ऐसे ही हैं, ये तो जब से शादी हुई है तब से ये ऐसे ही हैं, ढीले रहते हैं, एकदम ढीले पड़े रहते हैं. So I don't know, do you have any questionnaire in the OPD? You have point system for questionnaire that if daytime somnolence is there, 5
one
points.
is the Epworth Sleepiness Score, ESS. You can download from the net, Epworth Sleepiness
So
Score.
do you write, madam, when you take a patient, everyone that's, if you give it to us, we will also write it in our history taking, that heart failure, all heart failure patients, all low atrial fibrillation, which we consider low atrial fibrillation, may not be low atrial fibrillation. OSA may be the cause in that, isn't it?
So it's a very important observation here that Dr. Brajesh has pointed out. I'll tell you what I personally believe, and we were just chatting, Dr. Anuradha and I, sleep problems are now so ubiquitous, right? Be it poor quality sleep, fragmented sleep, melatonin deficiency because of all the other things. Our modern lifestyle is so far removed from the way God designed us that this is ubiquitous. So like these things, इनका energy level पहले से ही कम है, हमेशा रोती रहती है. These are all subtle things going on, migraine, anxiety, depression, and every one of them has a correlation either with sleep quality, quantity. So I think we all need to, right from the GP to the super specialty level, understand that sleep is not just those 8 hours at night. It is the entire 24-hour circadian rhythm which needs to be optimized for better health.
Thank you.
We can talk endlessly, so I think we should stop here.
I would like to request Dr. Jayalakshmi ma'am to please felicitate our speaker and the chairpersons along with Dr. Sangeeta and Dr. Ravindranath Sahai. Sangeeta ma'am, Sahai sir, please take the podium. Ma'am is felicitating Sangeeta ma'am. Next up, we have Dr. Girish Nair as our main speaker and the chairpersons for the event, Dr. Rahul Verma and Dr. Shrikant Tiwari. It is my privilege to introduce Dr. Shrikant J. Tiwari, consultant in pediatrics and neonatology at Apollo Children's Navi, Mumbai. Dr. Tiwari holds an MD in pediatrics, a fellowship in neonatology, a diploma in hospital management, and over a decade of clinical experience. Dr. Rahul Verma, IDP CCM, DNB DCH, consultant pediatrics and pediatric critical care, Apollo Hospitals, Navi, Mumbai. I would request Dr. Rahul Verma to introduce our speaker.
Thank you. Good morning, everyone. Thank you to Dr. Jayalakshmi ma'am and Dr. Bhumika for inviting us here. It is our privilege to introduce Dr. Girish Nair sir, who is a very renowned neurologist with over more than 17 years of experience in field of neurology. Sir has been academically very inclined right from his undergraduate days. He has been a gold medalist in anatomy in his MD and DM neurology tenure. Sir has multiple research publications to his name, and sir is a guiding force to all of us for not just for neurology, for other things also. Sir, please go ahead.
Thank you. While the slides come up, I'll use my time to quickly get a sense of where we are with to pill or not to pill. You know, that's the big question as a neurologist. Lovely. Thank you so much. So quick show of hands. How many of us are seeing patients who complain of a problem with sleeping? Lovely, almost everyone. And typically in an office visit, how often do you feel pressurized to prescribe a tablet to help them sleep? Show of hands, all the time, correct? Okay, now this is a question basically for people who are, in general practice, internal medicine. How often do you end up prescribing a benzodiazepine? Any show of hands here? Okay, cool. I appreciate that. No judgment, please, no judgment. Specifically, how many of you end up prescribing alprazolam? Okay, here is the disaster of our practice, so to speak, and I'll tell you quickly why that shouldn't be the case. So quickly going through some, fortunately for me, I have some very good speakers who've covered the basics, so the first set of slides is all just a quick revision. Yeah, so the typical presentation, yeah? These are all the kind of questions that we come up with in the clinic when we are interested, not just interested, we're in practice, we're looking at sleep disorders. Either they wake up too many times or they wake up too early, they sleep, but they don't feel refreshed. I think that's a very common thing. That is the litmus sort of test I would use to check whether there's a significant sleep problem. My mind does not switch off. It's a very funny thing. People tell you, and it's a very common report, that I don't feel relaxed at all. Actually, that's a report of underlying anxiety, and I'll come to why that is important, because hyperarousal is one of the reasons why you don't get quality sleep. And this is a typical sort of symptom that points towards it. I am tired but still cannot sleep. Again, any very, very common report, another symptom of hyperarousal. Yeah. So yeah, as I said, and you've heard before, it's not just a nighttime problem, it's a 24-hour problem. And basically it means that your circadian rhythms have not been optimized, and that is the reason why you saw all the long-term health consequences, heart problems, from my side as a neurologist, dementia, anxiety, depression, other neurodegenerations, accelerated stroke risk, as well as now we also find there's an increased risk of certain types of cancer. Now, why insomnia matters? The whole thing, see, again, this is mostly Western data. The daytime implications, especially in terms of fatigue, cognition, and function. Now, let's give you a little example. I mean, most of us as doctors, we get calls in the middle of the night. Now, let's say you've had 4 to 5 calls in the middle of the night. You woke up, you actually went to the hospital, did an emergency procedure. Some of our cardiologists do it, our NICU team does it all the time. The next morning, when you're driving to work, how often do you feel that your peripheral vision has failed, you almost banged into someone, So the implications of poor quality sleep on daytime functioning is hugely underrated, right? If we can just work together to get that part sorted, I think fatigue, cognition, function, all of these significantly improve. Now, why talk about insomnia? I think it is the elephant in the room. And when I have a patient who comes to me with vague symptoms, not feeling okay, aches and pains, one of the common things that we need to look for is what is the quality of sleep. It is never thought about. If you ask them, it's a directed questioning, they may come up with issues. But most of the time, like we just heard, people assume that they don't have to sleep too well, or people assume that falling asleep during a boring conference is routine. It's not actually. Even if it's, I will come to that in a little bit. Yeah. So in order to call something an insomnia disorder, we need to look at what is the problem with sleep. Is it a sleep onset problem? Is it a sleep maintenance problem? Is it a sleep offset problem? Or is it excessive daytime sleepiness? What is the daytime impairment in terms of each of these? So fatigue, mood. By the way, people who have not slept well are naturally irritable, because intrusions of stage 1 NREM into wakefulness is one of the most common reasons for anxiety and depression. So this is a recently discovered fact. And this type of stage 1 intrusion into wakefulness is also an important risk factor for developing amyloidopathies, predominantly Alzheimer's disease for us as neurologists. Yeah, so so these are a few numbers. I think this is still a little bit of underreporting. I would personally, in my own practice, I would think that the numbers are significantly higher. So yeah, not just poor sleep, but the whole gamut of things that go wrong when you're not sleeping well, and particularly, once again, coming back to cognition, mood, ability to function and focus. So yeah, causes of insomnia, this is important to understand. This is a very important matrix I would always like to look at when a patient says he or she is not sleeping well. Are there any underlying medical conditions? Is there heart failure? Is there chronic kidney disease? Is there uncontrolled diabetes? Very, very important, because these are all contributing to the quality of your sleep. Mental health conditions, anxiety, depression, certain types of psychosis, especially which are associated with the hyperarousal states, certain medications. Now, the typical ones, steroid, for example, pulmonologists would use it when they're trying to treat a bronchospastic airway disorder. But yes, steroids are notorious for disturbing the quality and quantity of sleep. Irregular sleep routine. Now, this is very important to ask, because I find two categories of patients in whom this irregular sleep routine plays an important role. One is a typical, quote, homemaker who has some free time during the day and then thinks that it is her time to sleep. You just heard from Dr. Anuradha and the others why it is important, and I will come to that in a later slide, to build up a healthy sleep deficit during the day. I have senior citizens who have retired, who have nothing much to do, who sleep during the day and then complain that they're not able to sleep at night. So if you can encourage a patient with insomnia to build up a sleep deficit by correcting their sleep routine, have that window which is in sync with the circadian cycle, the 10:30 to 6:30, which is typically the best time for a person to fall asleep and wake up refreshed, I think a lot of our problems are solved. But people, it's difficult. In today's time and age, like last night, I was up till about 2 a.m., couple of phone calls, one patient collapsed in the ICU. We are all dealing with that. So I didn't go to sleep till about 2 a.m. and then I wake up at 6 a.m., which is my routine. So late night work hours, shift work is very, very common today here in our hospital as well. Stress, no one talks about this. What stress does to you is basically it makes you an anxious person, and an anxious person is hyper aroused. They cannot fall asleep. So they may either worry about falling asleep and then not being able to function the next day, or they may worry about other things. But the bottom line is your sleep is affected. Very, very important, poor diet choices. We have now very interesting data coming up from studies of what we call the gut-brain axis, which tells us that a diet which is rich or high in processed food, especially simple sugars, trans fat, certain food additives, especially preservatives, MSG, which is something that is around a lot. I'm not talking about natural MSG, which is the umami flavor of certain foods. I'm talking of the synthetic MSG. All of these are known to disrupt your sleep. This is something we are all aware of, very quick. Excessive daytime sleepiness, we spoke about the Epworth scale. Irritability. Now, when someone is just irritable for no good reason, remember, it is stage 1 NREM intrusion, one of the very important differentials. Delayed reflexes, what I just told you about, bad night, next day you're driving, you can have like a fender bender because of that. Memory issues. I'll spend a minute here. We have a potential Nobel Prize for medicine coming up for discovery of what happens to the brain if you don't sleep well. Now, we have found that everything from the quality of the sleep, the position in which you sleep, and presence or absence of OSA is responsible for failure of the glymphatic system. The glymphatic system is basically the glial lymphatic system, which is the cleaning system of the brain. So if you get 7 to 8 hours of quality sleep, your glymphatic system is working well. And all that gunk, the amyloid, has been then cleared. If, for example, you're snoring or you sleep in the prone position, and other factors as well, your glymphatic system is not working well, it significantly increases your risk of developing Alzheimer's dementia. So quality sleep is very, very important for cognition later on in life. And of course, trouble concentrating, disruptions in work, kind of repeating on the same theme. Daytime consequences, I think we've gone through all of this in a big way, and I won't spend too much time. Yeah, this is a very, very important slide. This is a matrix I follow when I'm seeing my patients, the 3 Ps. And I think there's a very practical take-home point. If I have a patient with insomnia, I do a checklist of the predisposing, the precipitating, and the perpetuating factors. If we are able to do this properly, I think we do have an answer to every type of insomnia that the patient comes up with. So what are the predisposing factors for insomnia? There are certain traits. For example, some people, a type A personality, a person who's a go-getter, who worries, who plans, who overthinks. Yeah. Then, of course, genetics. For example, there are people in my own family. My father was a light sleeper, did not require too much of sleep. On the other hand, my mother, even at her present age of 81, is very happily sleeping 8 hours a day, very cheerful. So that's a little bit of a genetic factor there. Anxiety, very, very important. So there are some personalities who are anxious to start with, all right? And that affects their ability to relax. And I'll come to that in a little bit. CBT is something we've been speaking about a lot. In fact, it is the cornerstone of therapy in the West, not so much freely available here. I think the expertise is not very freely available, and hyperarousal. The precipitating factors, again important for us to understand, a physical illness, grief, pain, especially a physical illness associated with pain, stress, schedule changes. For example, a person who's having to work a different schedule, the body has gotten used to something. And of course, the perpetuating factors. See, once the problem is there, people do their own things to get around the problem. And that is where a lot of the issues lie. These unscheduled, unscientific naps, you just heard, if you need to do a nap during the daytime, it has to be extremely short, 20 to 30 minutes, not more than that. And even if you don't feel okay, just get up and get on with it. You will build up enough sleep deficit to be able to sleep properly at night. This extra time in bed, and that is kind of relearning the bed-sleep association. We'll come to that in a later slide. Clock watching, I'll come to that, very, very important. A lot of people feel, oh, tomorrow I have a big presentation, or I have a big meeting, I have a long day, I have a 40-patient OPD. What will happen? Will I feel sleepy at 4 o'clock? Will I doze off after lunch? Will I zone out? Will I be an embarrassment? Safety behaviors. So again, things people do, to ensure that they're safe can actually perpetuate this problem. Counseling is very important here to understand. So just basically the 3P model, I have just gone through all of these things. One very important thing I would like to point out is using alcohol or over-the-counter. Unfortunately, in our country, over-the-counter sedatives are used and abused. I would say abused, not used. The rest is pretty self-explanatory. Now, the hyperarousal model, it's a combination. So there is a little physiology going on. You're wired that way. Emotional arousal, there could be triggers there. You're worried about something. Cognitive arousal, because you're thinking through something that you've been working on. And this leads to a combination of what we call conditioned helplessness and sleeplessness. I call it conditioned helplessness about sleep. Again, how does one transition from an acute to a chronic insomnia? If you look at the 3P model, there is a predisposition, and then there is a precipitating factor, which could be a physical illness, bereavement, stress, and some maladaptive behaviors perpetuate. And that is how we go across into this phase where a person is completely unable to sleep. So again, there are a few things we look for in the clinic. I typically go for sleep initiation difficulty staying asleep, waking up too early, feeling unrefreshed, and excessive daytime sleepiness and the impairments that go through. Also remember, it is never a standalone problem. In my own experience, the largest number of, I would say, comorbid conditions happen from the psychiatric basket. There are also other comorbidities that you just saw from the other specialists. Chronic pain is, by the way, a very important thing to understand. Fibromyalgia, again, a hugely underrated, hugely underdiagnosed condition. The patient is just, till about 4 years ago, we were not even completely cognizant of the fact that fibromyalgia is organic. Today, we have functional MRI studies that show that the pain pathway, the thalamocortical projections that are responsible for pain mediation are in a state of hyperactivity in patients with fibromyalgia. So when a patient comes and tells me that, doctor, kapda chhuta hai tab bhi mujhe sandpaper jaise lagta hai, that is their lived experience. So it's very, very important for us to understand that chronic pain is something that can severely impact quality of sleep, quality of life. So fibromyalgia is a very important thing for us to remember. Now, sorry, battery is running low. Okay, no worries. I'm running out of time. Let's quickly go to the pill part, which is the, thank you. Can we do? Good. Let's go to the pill. Yes. Yeah. So of course we do a comprehensive assessment. I won't, this is all part of the questionnaire that we do. All of these implications, I will not spend too much time doing these things. Yeah. Another point I want to make here is screen exposure. One of the most important things that disrupts the body's ability to generate enough melatonin for a good night's sleep is too much screen time, and most of us are guilty. Ideally, we say not more than 1 hour in 24 hours, but for a person who is doing a lot of work on screen, I have a little hack which also works quite well, and this has been studied in small sort of studies, taking a 2 to 4 minute break every 30 to 40 minutes of screen time. And in those 2 minutes, if you can encourage this person to do any activity that causes the heart rate to go up. So you can do like maybe 100 steps of jogging in place, or you can run up and down a flight of stairs. Yeah, stretch and then come back. That mitigates some of the ill effects of prolonged blue light exposure on the ability of the body to make melatonin. So yeah, as a neurologist, I'm always worried about parasomnias. So all the spectrum of things that go bump in the middle of the night, so very important to ask. Sometimes the patient himself is unaware. It's a family member who points out that they're talking in their sleep, there is restless legs, there's the Ekbom syndrome, and all of that. So very important. Yeah, medication-induced sleep disturbance. Whenever there is a psychiatric co-prescription, I would be very interested. I would also be very interested in the use of certain over-the-counter stimulants. Some stimulants which are present in cold medication. I've seen so many patients who are constantly taking something for a blocked nose, and that could be one of the factors here. So when is a sleep study required? I have a very low threshold. I think we lost that. But I'll continue to speak. I have just 3 or 4 slides to go through. So I typically have a very low threshold of a sleep study referral when the patient reports excessive daytime sleepiness. I don't hold back, because everything from falling asleep at the wheel to impaired work performance, I don't compromise, because like we just discussed, not every patient with OSA snores. Not every patient with OSA is obese. So we have to be a little clear, lateral thinking, in terms of not getting crippled by our adherence to a stereotype. So I had 3 more slides to go. I will quickly summarize what I had to say there. When do you offer a pill-based treatment, right? Where do you offer the tablet? What are broadly the types of medications we have at our disposal for treatment of insomnia? We have the very commonly and inappropriately overprescribed benzodiazepines and the Z agents. Now, very, very, very frequently overprescribed and abused drug is alprazolam, and it has disastrous consequences long term. For a very short period of time, when there's a clear stress, there is a bereavement, or there's a major medical illness, for example, an acute myocardial infarction, for 2 to 3 weeks, it is okay to use a very low dose of alprazolam, but with a plan to taper off and stop it. Now, the key word here is taper. Abrupt stopping results in a rebound, insomnia. It results in rebound dysphoria, both of which are extremely unpleasant for the patient. So have a protocol after 3 weeks to offer an alternate day for 2 to 3 weeks and then to completely stop. In patients who have trouble getting off their benzos, we need to build up a few other important things. It's okay, don't worry, we'll finish. So it's very important to work on CBT, cognitive behavior therapy, which I think is the cornerstone, training people to understand at every level, emotionally, cognitively, why they're not able to fall asleep, and use the services of a good psychologist who has training in CBT to help them overcome their particular matrix set of problems that needs to be addressed. So CBT, very important when you're dealing with chronic insomnia. If they have been abusing the benzos for a long time, that they need to be weaned off and they need to be bridged. So we have to understand what is happening here, offer them melatonin or Rameltion, which is very safe, for a period of time where they're able to relearn a new sleep cycle, practice sleep hygiene, and get back to a normal sleep-wake schedule, and then take off the benzodiazepines. That's a more pleasant alternative. Now, the last new kid on the block that we're all very excited about are the orexin, antagonists. Thank you. Okay, no worries. Let this thing, because others will run out of time. So yeah, in terms of drugs, where do you use the Rameltion? Rameltion actually works quite well. No worries, no worries. It'll take too long. Yeah. So yeah, we have lemborexant, which we are using quite a bit now, at least in my practice, I use quite a bit. So basically, these are the orexin receptor antagonists. Orexin receptor antagonists have two very powerful benefits. They don't cause excessive daytime sleepiness. Patients are not very happy when you're transitioning because it doesn't work like that, but it does work long-term and sustained, and they're much more easy to taper off and stop once the problem has been solved. The long-term solution for any sleep problem, very rarely do I need to keep a patient on a pill long-term. There are specific neurological situations where I do prescribe a long-acting, or I would say moderate-acting benzodiazepine like clonazepam. But the typical short-acting anxiolytic, alprazolam, etc., long-term use is contraindicated because of the gait problems, the ataxia, the cognitive dysfunction that happens. So to quickly summarize, since I've taken up quite a bit of your time, at the end of these 15-20 minutes, the next time we see a patient who wants a pill to sleep, would you still go back to your alprazolam, or would you spend an extra 5 to 10 minutes understanding the 3 Ps? And if you can figure out there, between the predisposing, the precipitating, and the perpetuating factors, what we can optimize. One of the important things which works extremely well, if patients are willing to try it out, I ask them this question: how keen are you to be able to really get back to sleeping the way you did as a child, right? If the answer to that is a strong yes, I tell them there are no shortcuts, but there is a process we can go through, right? And some of this is CBT, but since I don't have a person who offers me that kind of CBT, I give them a few important tips to relearn the connection between the sleep bed habit. So A, practice sleep hygiene. Avoid caffeine-containing beverages at least 5 hours before sleep time. Maintain a fixed time to go to bed, ideally about 10:30. Restrict screen time, especially after sunset, after 5 or 6 p.m. Use the bed only for sleeping, right? Once they go and lie down, within 10 to 15 minutes, if they have not slept, they must come out. Yeah, come out of the bedroom or the sleeping area, come back to the room where they would otherwise sit. Identify 3 to 4 books that are completely boring, zero interest to them. But no, this works like a charm, by the way. I tell them, go back, what was your worst subject in school? Hindi? Okay, get your Hindi textbook, keep it there, and start reading. The moment you fall asleep, close the book, go back, lie down, right? Do this, you wake up in the middle of the night, do the same thing. No getting up, scrolling, no listening to music. Do not do something which is interesting or potentially arousing. You have to identify a soporific activity, right? Do this, the moment you feel sleepy, come back, lie down. If you can stay with this for 21 days, 99% of the time, your problems with sleeping are going to be sorted, right? There are other additional techniques, meditation, mindfulness works very, very well. I mean, here we are in the land of wisdom in every spiritual sense. If you can practice pranayama, I find pranayama and meditation very, very powerful, basically to calm yourself down, center yourself down, and everyone is super stressed. So these are small, simple things you can do. If there is chronic pain, there's a fibromyalgia part, we get that sorted. So to ensure that the patient sleeps well. So a lot of your time, thank you very much for your attention, and a big shout out to our pulmonology team led by Dr. Jayalakshmi, Dr. Bhumika and Dr. Arjun, who have been absolute champions, because ever since Dr. Jayalakshmi has launched our sleep lab, I really think we have transformed a lot of lives. People have come back to me telling me that, doctor, I feel born again, you know, after my OSA was corrected and the sleep problem was identified. Thank you very much. So that's a very, very important question. Apne, Bhumika, I'll use that microphone. I prefer walking around. Cramps my style to stand behind there. Yeah, very, very important. And this is the bulk of the problem. They have been started. It's the shortcut, right? So what I would do, Dr. Sangeeta, is I sit them down, right? It is not a shortcut. I tell them. So this is where the question comes. I ask them, how keen are you? How committed are you to solving this problem? I'm coming to that. No, I'm coming to that. So when they say, मैं छोड़ना चाहता हूँ और मैं छोड़ नहीं पाता हूँ, I ask them, how committed are you to stopping this? Because right now, it's affecting your memory. You feel low during the day, your balance is off, right? And you already had a fender bender recently, and your wife is worried about it, correct? This is the situation we are in. How keen are you? Because what I need to do now requires a patient to take a decision and own it. Right? मेरे सामने बोल दिया, wife के सामने बोल दिया doesn't work. I said it has to be your decision, you have to own it, because everything else that follows is lifestyle changes. And then I go through the 3 Ps, right? I find out what was his premorbid personality, right? Did the restful start after a heart attack or after a road traffic accident? When did it start? What was the precipitating factor? And the perpetuating factors. He's sleeping during the day. He's watching TV in bed, right? Then he goes for coffee at 7 p.m. So you have to do a full audit, and it's not easy. But if there is a committed patient who's willing to follow your instructions, including silly sounding things like identify 3 boring books, and so आपको 15 minutes में नींद नहीं आया तो आपको बाहर आके वो boring book पढ़नी है. These are not, I mean, when they walk into my office, they are expecting a super pill that will help them sleep like a baby forever. Doesn't exist and should not exist also. I feel sleep has to be earned. If you're sleeping like a baby, you've got to have the innocence of a baby. तो innocence तो चली गई है, but ये बाकी चीजें हम लोग relearn कर सकते हैं.
Thank you, Girish sir, for such a precise and excellent presentation, sir. Sorry. Thank you so much for the excellent presentation. It was quite good.
Thank you, sir, for the wonderful oration.
I would like 20 minutes. Thank you, sir.
Thank you, sir. I would like to request Dr. Bhumika Madhav to felicitate the chairpersons and the speaker. Thank you. Next up, we have our presentation on drug-induced sleep endoscopy. The speaker is Dr. Harshad Nikte sir. The chairpersons for the event, Dr. Shubhodip Sen and Dr. Divya Kukian. I would request the speaker and the panelists and the chairperson to please come up on the stage. Dr. Shubhodip Sen, MBBS from Medical College, Kolkata, MD Anesthesia, SSKM and IPGMER Hospital Gold Medalist, Diploma, ECMO from Paris, DNB and ITCCM teacher. It is my privilege to introduce Dr. Divya Koken as well, consultant in critical care medicine and intensivist at Apollo Hospitals, Navi, Mumbai. Dr. Koken brings over 15 years of extensive experience in management of critically ill patients. She holds an MD in internal medicine along with IDCCM and FCCM. Thank you.
Yes, good morning all. I am Harshad, I am a consultant ENT over here.
Everybody. So what the next, so first of all, thank you for inviting us, for both Dr. Divya and me over here. Over the next 15-20 minutes, Dr. Harshad Nikte is a very dear colleague of mine, and he's a senior consultant and the ENT surgeon over here. Over the next 15-20 minutes, he will talk about this drug-induced sleep endoscopy, which is one of the very novel things that came in the field of the sleep medicines in the last few years of time. Over to you, Dr. Nikte. Thank you.
Thank you, Dr. Sudeep. At the outset, I would like to thank Dr. Jayalakshmi and Dr. Bhumika. So, the previous speakers have all told about the pathophysiology, the effects, how to do. So, I am restricting my talk only to the aid of diagnosis. So we all know that the sleep disorders, the treatment and the diagnosis is very important. So diagnosis gold standard is by doing a sleep study. So I'm going to talk about something called as DICE, that is drug-induced sleep endoscopy, which is going to aid to the diagnosis of sleep study. So are we right about having the diagnosis? So what are we going to cover in this is, what is the need, why we need to do the sleep endoscopy, in whom we need to do it, why, and how are we going to do it. So patient selection is very important. This is an observant-dependent study. What we are going to diagnose here is the upper airway collapse patterns. So at what level is the obstruction? Sleep study is going to diagnose us with what is the respiratory RDI, the AHI, how much the oxygen is dipping, how much pulse rate is increasing, but where is the site of obstruction? That becomes a dilemma. So there were many tests, which was, one is very enchanting, which is non-invasive, because sleep endoscopy becomes a semi-invasive kind of test. So MR endoscopy is also very prominent, but still the kind of sedation which needs to be given and at what level the patient has to be sedated becomes a challenge. So please understand that DICE is an aid to diagnosis. It's not a preliminary test what we are going to do. Not in every patient we are going to do DICE, where we have a clear-cut diagnosis, a clear-cut level on the sonography. On the sleep study, we are going to diagnose, and the patients are going to come to us to subject them to a drug-induced sleep endoscopy. So why it helps? So DICE is basically a dynamic study. So we are going to put the patient to sleep, and we are going to observe how much and at what level, right from the nose to velum to oropharynx and going down, how much and at what level is the obstruction. People usually have multiple level of obstructions. It's not like a simple thing where you have an obstruction, say like a retrograde kind of a patient, a broad thing, an obese patient. As the previous speakers have spoken, obesity is not directly related, that you may have an obstruction at only a single level. So what are the basic principles of drug-induced sleep endoscopy? We try to give some amount of sedation. I will let you know what medications do we try to induce a level 2 kind of a sleep where the patient is sleeping, but he can be easily aroused. So we put the patient to sleep, and then we will see how he deteriorates in the way of his oxygen level going down. So I'll just tell you in the brief thing. So once the patient is put to sleep, what we do is we pass a small endoscope down through the nose, a flexible scope, and then see how the level of obstructions and a dynamic assessment of the collapse is observed. So as I told you that the sleep endoscopy is a aid to diagnosing and aiding the sleep study. So how much is the AHI level dipping? How much oxygen desaturation is happening? So based on the diagnosis and along with sleep study, we can come and arrive and tell the patient what exactly is needed, whether you need a therapeutic way in doing a surgery or you can continue using the CPAP machine. So once we have a patient who comes to office, usually a pulmonology team is going to refer that to doing a DICE. So we are going to understand on the patient, his structure, his build, his symptomatology, his sleepiness scale. So once we are through our history taking, then we subject the patient to sleep endoscopy. So typical contraindication of where we are going to avoid the DICE is basically people who are unfit for taking that kind of anesthesia, because we are going to give sedation, we have to observe the patient whether there's any kind of respiratory arrest should not happen. Because there's a very fine line between giving sedation, at the same time the patient should not go into respiratory paralysis. So that is very, very critical. So what is the checklist what we do? So confirm the diagnosis of the patient, reviewing the sleep study findings, then making the sleep study findings aware to the anesthetist, because the anesthetist is going to give the medication. We have to make them aware that this is the lowest saturation of the patient on the sleep study. This was the type of AHI, this was the heart rate which was elevated. This is very important because the anesthetist should be in track with us. The moment they say the saturation going below 90, there should not be any alarm. They will suddenly try to intervene. Suddenly the patient may have tachycardia. Then the patient, again the anesthetist will try to pull it off, because that is going against the safety standards of the patient. So anesthesia risk, then checking the fasting, because patient needs to be 4 hours fasting before we subject the patients to DICE. And the monitoring, we always do the patients in our sleep endoscopy or either in our ORs. So patient positioning, the patient is in the supine position. We keep the patient in sedation. Usually the preferred drug either is midazolam or propofol or dexmedetomidine. So once the patient is administered the sedation, a flexible nose endoscope is inserted, as I told you earlier, and then we observe the pattern, what exactly is going to undergo. So I'll just go through that. So this is the same thing which I have told about. The patient should be in a sleep-like state. So how are we going to think that the patient is there? So usually we have a trick where if the patient is too deeply sedated, we are going to pull the pinna, pinch the pinna and see if the patient is waking or not. So what I usually do is when the sedation is given, I usually prepare propofol and we ask the patient, and I keep on talking to the patient. So in a normal conversation, if we have anybody at home, we are talking and we can see the patient doze off. So similarly, on the table, the patient is going to doze off, and that is the time we introduce the scope. Otherwise, I keep the scope inside the nose, keep on talking to the patient, and then the moment we find that the patient has slept, that is the time we progress our endoscope from the nasopharynx down. So these are the 3 common most used agent. Some people use midazolam, but midazolam has a long sedation effect. So we want the procedure to be office-based. We want it to be quick. We want to do it in the morning, and then in 2 hours the patient is sent home. So Dexmed is a bit expensive drug, so I prefer propofol. Propofol induces sleep beautifully, and the patient also wakes up very nice. So one more thing which happens with propofol is all the patients says कि doctor नींद बहुत अच्छा आया. इतना दिन में आया नहीं, but with propofol I don't know how it works. I have never had to use it on myself. So on the sleep endoscopy, there are these 4 cardinal levels: soft palate, oropharynx, base of tongue, epiglottis, and hypopharynx. That is the lower part which we are going to have. And we grade it based only on this scale of VOT scale, where we are going to have the obstruction, either it is complete, incomplete, partial, or circumferential. So the same sites described in this diagram. The grading 0, 1 and 2, that is none, partial, complete, and the pattern. So the patterns is very important, because this pattern is going to guide us whether we need to intervene the patient surgically or we are going to give the patient some other form of treatment. So the most common thing what we find in patients is having a soft palate collapse. So usually we are going to have lateral collapse and anteroposterior collapse. So when you are doing a sleep endoscopy, we can see the movement happening up and down, or mostly the lateral. So at the velum is most common site which are going to be there. So as we understand, the treatment choices are the palatal surgery, UPPP and the expansion, and the hypoglossal nerve stimulation still in evolution stage in at least our country. So oropharyngeal collapse is that the place where you have tonsils, your base of tongue, and at that level. So usually tonsil is the male culprit along with the bulky muscle called as palatopharyngeus along with palatoglossus. So if you plan over here, this is an elongated uvula for the patient. These are the tonsils happening behind, and this is the soft palate collapse. So this usually is still looking wider. This is just a picture being shown. So when we subject the patient, very rarely any of us are going to have this big as an opening. So if people are having short fat neck or maybe obese neck, they can have at the maximum a partial lateral collapse. So in normal individuals, you will have open airway or partial lateral collapse who have good neck. Another way of finding and talking about diagnosing the patients in office, whether they have that, you just have to look for the patient's neck. So if the patient has long, slender neck, very unlikely there will be any cause behind, provided the mandible is forward. So some people will have long neck, but the mandible will be short. So in those people, what happens is the base of the tongue is shifted behind, and that is the reason you get collapse either at the hypopharyngeal level or at the oropharyngeal level. So as I was discussing just that the tongue base is there, so you understand your posterior 1/3 of the tongue is usually having lots and lots of lingual tonsils. So people having acid reflux, because sleep apnea is going to induce reflux also to the patient. Patient cannot sleep well, that is the reason patient is going to have acidity. So this acidity we always treat all the patients with pantoprazole or abeprazole. So we understand and we forget that the acid which is coming is going to disturb the lingual part, the lymphoid tissue which are basically on the tongue. So the posterior half of the tongue, this is how you have lingual hyperplasia, and that causes, and that is sitting at an area between the epiglottis and the tongue, that is called as the vallicula. So vallicula also puts pressure on the epiglottis, the base tongue also falls along with tetragrathia, and we observe a collapse at this level. So this is just the conclusion of the slide. So these are small endoscopic pictures, they are not clear, I'm so sorry for that. But this is what is the posterior part of the nose where the adenoids are there. So a normal individual will have an open airway, grade 2, grade 3, and a complete collapse over here. Then this is the velum, that is the nasopharyngeal part where there are collapses happening. And if you can understand, just look at this picture, this is what we are talking about. So this too basically needs to be therapeutically subjected to further procedure. The lateral pharyngeal pause, these are the vocal cords of the patient. So this is what we are talking about. In a normal individual will have this kind of a picture, but people having a AHI close to around 40, 50 will end up with this kind of picture, and this is 50 above, a respiratory index as well as AHI above 50. And tongue base, usually this tongue base and this epiglottis usually starts at the pediatric level where we'll have a picture of laryngomalacia. So this is called as basically a omega-shaped epiglottis which becomes very floppy. So when we are sleeping with the heavy base of tongue, the epiglottis keeps on moving and it shuts the vocal cords, the aperture of the larynx. So this will be a pediatric emergency, but as the child grows, there is good amount of ossification in the cartilage and it becomes stiff. But later in the adulthood, when they start becoming obese, then this becomes a problem. So this is going to collapse along with the weight of the tongue base, and then this becomes very difficult to be treated because it is quite lower down in the neck, and then it becomes a challenge. So as we were talking about, there are multiple levels of collapses which can be diagnosed, right out multiple levels. And the common levels, as I was telling you, was the first part, velum and the lateral wall. Welling and tongue base is also another set of this, or worse, we may have multiple level obstruction. So once we diagnose what is the level of obstruction happening at DICE, then we can give a better and the best possible therapeutic measure to the patient. So the last comes down to the level which is below the base of tongue. So we are talking about from the hyoid bone externally till the mandible here, mentum. So the hypopharyngeal collapse is a very, very common entity. It happens in short, obese neck. And what we are going to observe here is how much is the collapse happening. So this collapse here, it's completely obstructing. So there is at least 95% obstruction and there is no passage of air going. So these two are quite deadly to be treated. And at that time, these patients are usually going to come in some form of stridor or they are going to get confused with that. So this is again a diagrammatic representation of the levels. So when we are doing the sleep endoscopy, as I told you, we take our help with the anesthetist and we have to tell them prime and prime again that what is the level of oxygen we want to achieve. So if we have told in our sleep study, a patient having a saturation of 75, 76, that's the lowest dip of oxygen saturation. So we are mentally tuned and we also tune the anesthetist. They don't need to get worried about if your saturation goes below 76, 77. So that is the one thing which is going to be there. And once that, we do different kind of maneuvers there. We are going to give a jaw thrust, we are going to elevate, we are going to move the patient here and there just to check whether the collapse increases or the collapse decreases, whether the muscle tightens or they go in a different manner. You can also do manual advancement for the patient. You can have these mandibular devices which are there. But as Madam told earlier that patients have CPAP related issues, so with the mandibular devices also they are not very comfortable. In pictures they look very fascinating, but people using them, they have a lot of difficulty to keep them in place. It's a foreign body object right in your mouth. So this also has poor compliance. So we jot down our findings once we do our DICE. So we are going to find and at what level we are finding the obstruction, we are going to rate them. And based on that, we have a score which comes and then we can offer them either a medical management or either the surgical management. So the management, basically we are not going to go in this, but these are the basic management about what we do as a therapeutic measure to treat. So once a therapeutic measure is done, so for example, if you operate the patient upon UPPP or opening the passage, reducing the base of tongue, opening up the nose significantly, opening the velum significantly, then we do a follow-up study also because we want to see whether our procedure has been successful or not. So usually what we do is after doing our surgery, we get the patient again 4 to 6 weeks later, we do a sleep study and just check the score, how much we have achieved. So what are the limitations of DICE? So broadly speaking, there are no limitations. Basically, any patient who is a high risk for anesthesia, we have to be very careful because we don't want the patient to go into any kind of complication because it's a simple office-based procedure. So people having severe cardiac issues, people having severe pulmonary issues who cannot subject even a small dose of propofol for 10 minutes, usually then we'll avoid, but till date we have not even postponed any patient because then we will keep the patient updated and we'll take all the possible clearances. The only limitation which happens is you need to have a good setup to do this. You need to have a good Boyle's apparatus to do this. You need to have a very good endoscope because when we are doing that, we have to record each and everything. So the visibility is very important. So a good endoscope and a good company's endoscope usually is, and that is the reason the cost and the availability goes down. And last is the snapshot. Means it's such a dynamic procedure, you may have parameters going haywire here and there is suddenly a shout to help. Someone will panic over the oxygen saturation, some will panic at a heart rate of 140, 150 and the panic button is pressed. So at that time, we tend to lose what we need to record. So since because the procedure is going to get over in 10 to 15 minutes. So what are the key take-home messages? We need to identify what cases needs this drug-induced sleep endoscopy. Not every patient does, but the advantage is that it is a specific test for the specific patient so that we can advise and recommending the best possible treatment. We can integrate the modalities of treatment, how much the patient needs, what kind of supportive treatment the patient needs. And we always keep on repeating the drug-induced sleep endoscopy maybe once or twice in 2 to 3 months, just to see whether we have achieved what we wanted. So once all the therapeutic measures are set in, then to see in the progress our treatment, how it is. But this DICE is an evolving field. The reason I say so, because when we started working on that, initially there was a device called with Ryle's tube, which has sensors at 5 levels. It's the sensor started at velum, then there was tongue dip at the base of tongue, then the hypopharynx, upper esophageal sphincter, lower esophageal sphincter. So it used to give us a better idea, along with sleep apnea, whether the patient also has reflux. So the lower esophageal and upper esophageal sphincter, they also move according to the sleep pattern. So whether the patient has any reflux happening, but since again it is an invasive study, you have to admit the patient a day prior, do that. So DICE becomes a better study, a quick procedure where the patient can go back home in 2 hours. Thank you. I'm really happy to take any questions. Thank you. I'm sorry? Cost, I have no idea, but it is in an office procedure, should not cost much.
Achha, I have one question for Dr. because this is a very novel diagnostic interventions probably recently has come. So when we sleep normally, so we follow a typical sleep architecture, some part of the REM sleep followed by the NREM sleep, and the pharyngeal collapse that happens in the NREM and the RM, that they are variable, they are not similar. When we use an anesthetic agent or any sleep medicines, or any of this propofol, midazolam, dexmedetomidine, whatever we use, they do not follow the typical sleep pattern. They are not a normal sleep. So in that case, does the pharyngeal wall obstruction that happens in the OSA mimic that happens during the sleep, during the natural sleep?
So that is what we had put a limitation. So it doesn't mimic the true sleep, but as you go more and more experience, you can understand that whether the patient is actually sleeping or not. So the more the number you do, the more you will come to know, but that is always going to be a limitation. That is the reason new medicines are coming. So you have a study where it says that Dexmed is better than propofol in doing this, but Dexmed is an expensive drug, propofol is a cheaper drug. And the recovery of propofol, that alertness, what we want, that the patient should go back to home the same day. So propofol gives that advantage.
Sure. Thank you so much.
Thank you, Dr. Nikte, for a very good lecture. I had one question. So you're recommending this endoscopy for all patients who are undergoing a sleep study, or only for some select subset of
No,
patients?
this is a select subset. So we go through the sleep study report, we see, and then when we examine the patient anatomically also, we are going to feel whether there is need or not. So everyone was talking about snoring. So people come to me saying that the snoring sound is more. So I am saying that snoring sound is not important for what we are going to treat. We want to see the level of obstruction in your case. So usually with experience, you can judge where are the level of obstruction. Usually people coming to me will have a bulky base tongue. You can clearly see that there's complete soft palate collapse and the redundancy. And third is, we have to jot out what patient exactly needs, the level of obstruction. So some people will have a clear sleep study, they will not have a very high HI, and then we get a referral for that also.
Any more questions?
Then you can get an idea as to whether which stage the patient is in. So the light stage, deep stage, we are doing simple DICE, but there is advanced DICE where you can do with the sleep patient hooked up to the sleep monitor. We are not doing that. So, but that way the studies have been done, so they know exactly in which stage where the obstruction has come.
So that is not drug induced, that is natural.
No, drug induced. You're doing the endoscopy drug induced, but at the same time you're seeing the stage as to what stage, whether it's N3 or REM or whatever, N2. You can come to know at least the stages. But it has to be drug induced, because if the patient is in natural sleep and you try to do endoscopy, they will wake up.
Sure. Okay, thank you, thank you. If there's no more questions, then we'll wind up the talk. Thank you.
Thank you, sir, for the wonderful presentation. I would like to request Dr. Kiran Marthak to come up for the felicitation of the chairpersons and the speaker. Next up, we have our sleep clinic launch. I would request all the faculty to come up on the stage for the launch and do the proceedings.
इसको चालू कर दो ना डॉक्टर। हाँ वो मैंने डाल दिया ऑलरेडी, खाली चालू करना है। ये मैंने बनाया वो वाला है, ये वाला है।
So I welcome you all for the inauguration of our sleep disorders clinic. So since at the outset, I would like to thank ACCP as well as Apollo Hospitals for giving us the opportunity to do this session today. And since we are treating sleep disorder patients since last 10 years, since starting of Apollo Hospital actually, we have a full-fledged sleep lab where we do full diagnostic polysomnographies. We do the daytime MSLT studies, that is a sleep latency studying, mean wakefulness studies. So we have the whole gamut, as well as we have the limited sleep studies where we only see the respiratory parameters. So we realize the importance of sleep disorders and the importance of a multi-speciality approach multidisciplinary approach to this problem. And hence we have started a dedicated sleep disorders clinic where we will have the input of a neurologist, we will have input of a pulmonologist as well as a dietitian, as well as we will be doing the integrated with the lung function testing and the sleep testing. And also we will have the input of a psychiatrist and psychosocial worker as psychologist as required. So, and also the input of an endocrinologist. So, since we are planning to have this once a week session, once a week OPD, where we will have all the specialists who will see the patient real time in a continuous setting, so that we can do troubleshooting more easily and we can give the optimum treatment for our patients. So that was why we would like to launch our sleep disorders clinic. So thank you so much, and I think we can have the tea break now, and it will be followed by the further talks.
Hello. I would request all the faculty members and the teachers to assemble quickly. We will be starting our next session within a few minutes. We'll be starting our next presentation. I would request our speaker, Dr. Arjun Ramaswamy, to come up on the podium, and the chairpersons are Dr. Suresh Ade sir and Dr. Charan Reddy sir. I would request them to take the podium. The topic is when CPAP is not enough, NIV in OHS. It is my privilege to introduce Dr. Charan Reddy sir, consultant cardiologist at Apollo Hospitals, Navi, Mumbai. Dr. Reddy is a highly skilled cardiologist with over 8 years of experience in diagnosis and management of a wide spectrum of cardiovascular diseases. He holds impressive qualifications including MBBS, MD Medicine, DNB Medicine, DNB Cardiology, MNA MS, FACC, and an MBA in hospital management, reflecting his commitment to both clinical excellence and healthcare leadership. It is my privilege to also introduce Dr. Suresh Ade sir, MD Medicine, Diploma in Diabetes and Neurology UK, Fellowship in Neurology and Stroke. I would request our chairpersons to introduce the speaker, Dr. Arjun Ramaswamy sir.
So, I think without any delay, I'll start the talk, if that's okay. Yeah.
Actually, Arjun doesn't require any introduction. He's very talented, very expert pulmonologist. Since, I have been there for a long time in this hospital, I know him. and he's totally dedicated to his work. I think previous everything, is, I really don't know, but so far I know he's a good pulmonologist, he's a full-timer over here and managing his team properly.
Yeah. Thank you so much, sir, for your introduction. So without any delay, I'll just introduce a new concept here. So we have now seen about obstructive sleep apnea. Now we'll just look into the concept of hypoventilation. So OSAHS means obstructive sleep apnea hypoventilation syndrome, and OHS means obesity hypoventilation syndrome. So are both these the same? Not exactly, but more or less they're similar. So we are just discussing about hypoventilation syndrome here. So looking into the history, the entire concept about OSA came from obese individuals. So it was initially a Pickwickian syndrome in the 1956, where a pentad of things were noticed. There was obesity, excessive daytime sleepiness, hypercapnia, core pulmonal, and erythrocytosis. This was described as a character Fat Boy Joey from the Charles Dickens novel. So what is OHS? OHS is actually a combination of three things. There is obesity, that is morbid obesity with a BMI of more than 30, some form of sleep disordered breathing, most commonly obstructive sleep apnea, and third is a documentation of a daytime hypercapnia by your blood gas analysis. So you have your ASM criteria. ASM is the American Association of Sleep Medicine. So they have given criteria. Instead of a blood gas analysis, you can also use a transcutaneous CO2 monitoring, where a value above 55 or a jump of value of more than 10 from a baseline of 50 can also be considered as surrogate markers. So three things: obesity, daytime hypercapnia, and sleep disordered breathing. So these are the different stages in which the obesity hypoventilation syndrome progresses. So not everybody to begin with will have daytime hypercapnia. So the at-risk individuals are everyone who has a BMI more than 30. The stage 1 is said to be the obese individuals with BMI more than 30. They have nocturnal hypercapnia. That is, at night there is a raised CO2 that you can monitor in your ETCO2 readings in your sleep study, and the indirect marker, that is your serum bicarbonate values less than 7. If you note that in stage 3 and 4, that is the severe forms, there is sustained hypercapnia and there is also change in bicarb values. So this is the proposed classification based on the carbon dioxide values, mild, moderate, and severe. So this is just to classify how severe your obesity hypoventilation syndrome is. So what is the pathophysiology? So there are three different pathophysiological mechanisms that act here. One is the obesity-related changes in the respiratory system that increase your work of breathing. The second, because of this increased work of breathing, there is alteration in the respiratory drive. So there is central hypoventilation and there is also REM sleep hypoventilation. And the third pathophysiology is a sleep disordered breathing, such as a sleep apnea syndrome. So this is just the diagrammatic representation which shows the pathophysiological aspects. I'll just get a laser pointer. Yeah. So if you can see here, because of obesity, the fat deposition here, there is basal atelectasis. The lung expansion is reduced. The lung volumes are also reduced in obese individuals. So because of this, there is a alteration in the respiratory drive. So there is a decreased respiratory drive. So it actually, with time, when the respiratory drive decreases, there is buildup of CO2 leading to a daytime hypercapnic state. So again, there are three components in a morbidly obese individual which result in this kind of a syndrome, that is an impaired respiratory mechanics, increased work of breathing, and a disturbed sleep. So these in turn act on your respiratory muscles, your leptin receptors, your respiratory drives, and positive or negative influences or interactions among these will lead to an increased carbon dioxide production in the daytime. So how does this build up? So this is the exact mechanism of the CO2 loading. So initially you have normal breaths followed by hypopneas. Hypopneas lead to retention of CO2, and as a part of hypopnea, generally the next part is hyperventilation. So the carbon dioxide gets washed off. That is why normally an OSA patient, plain OSA patient, will not have hypercarbia. So, but when these apneas are prolonged, or when this hypopneas are prolonged, there is CO2 loading. This CO2 loading is not washed out in the subsequent days, which results in this persistent daytime hypercarbia. So what are the comorbidities that we commonly see? Cardiac comorbidities are very common. They are associated with heart failure, pulmonary hypertension, coronary artery disease. Hypertension is commonly seen, around up to 80% of the patients have hypertension, and this results in an elevated all-cause mortality of up to 24% at about 2 years. So why this hypoventilation syndrome occurs? It is because of, again, 4 factors. There is an underlying nocturnal upper airway obstruction, decreased respiratory system compliance because of obesity, decreased ventilatory drive, and leptin resistance, which is a ventilatory stimulant. So the management depends upon the phenotype. So for instance, like I said, it is a combination of 3 pathophysiological mechanisms. There is obesity, there is sleep disordered breathing. So if the sleep disordered breathing is predominant, the management is different. If hypoventilation is predominant, the management is different. So this is the importance of getting a level 1 sleep study. To identify all your hypoventilations, you require a level 1 sleep study. So once you identify the phenotype, you can manage like this. So an OHS with a predominant sleep apnea phenotype, that is when the AHI is quite high, it is more than 30, then CPAP is still the first line of choice. For responders, we continue CPAP. Responders as in there is adequate control both clinically and in blood gas picture you have your carbon dioxide which has come down. And in the CPAP non-responders are the ones who do not respond well to your initial PAP therapy. So the non-responders can be switched to NIV. So the crux of this slide is that the hypoventilation has got multiple components. Among that, the major component is still obstructive sleep apnea. So CPAP is sufficient for most patients with hypoventilation also. If the CPAP is not tolerated, that is if the patient is not responding to CPAP, then we can consider going for a bilevel ventilation, that is your BiPAP or an NIV. If in your sleep study, if in your level 1 sleep study, you identify that there are a lot of hypoventilations to begin with, and the AHI is less than 30. So here the phenotype is purely a hypoventilation phenotype. In such cases, we can upfront go with an NIV. So just going into a little more details. So there are 2 ideas here. OHS again can be classified as stable and unstable. By stable, I mean it is a chronic problem. There is no acute worsening of the chronic problem. For instance, the patient is having this obesity-related issues since quite some time. Unstable means there is an acute on chronic problem, such as the patient has a pneumonia or such as the patient has a heart failure, which has added on to the underlying underlying ongoing problem. So for a stable OHS, like I told, majority of OHS up to 70 to 90% OSA is the primary phenotype. So for that, CPAP is the mainstay of treatment. For a stable OHS which has a OHS predominant phenotype, you can go for a BiPAP. But for an unstable OHS, such as a pneumonia or a heart failure, then you will have to give supplementary oxygen also along with BiPAP. So how do you start treatment? How do you start treatment? You start treatment with your EPAP titration. You start with 6 centimeters, then gradually increase by 2 centimeters so as to stop the obstructive events. So this happens with a level 1 sleep study only. The technician titrates, based on your snoring, based on your apnea, he titrates every 2 centimeters to abolish the snoring and apnea. Then the second part is the titration of the IPAP. Generally, we have to start at 16. To overcome the transpulmonary and the transpleural pressures, a much higher pressure is required. Unlike for our COPD patients, we normally give lesser pressures. For such patients, we require much higher pressure, like probably say 16. Then you titrate it above based on your EtCO2 levels. So you go up to 16, 18, and so on. And finally, the oxygen part we give only in acute settings, wherein there is a pneumonia or a heart failure, just to overcome that part. So oxygen in stable OHSS can be detrimental. So again, this is just a stepwise titration. So EPAP, you can think of something to open up the airways. Some level of obstruction is there, you're just opening it up, you're making sure that the airflow is happening. The IPAP allows for the ventilation part. That helps to remove and push off your CO2. So for an obese individual, always remember the pressure support, that is the difference between IPAP and EPAP, should be at least 10. Not like your COPD patients where I give 6 or 7. Here it requires much bigger pressure support so as to overcome your transpulmonary and your transpleural pressures. So I hope this is not too complicated. This is a practical summary for all the clinicians. So stable OHS means pure, stable OHS means, obese individual with a predominant OSA phenotype. That is the most common thing that we see in our clinical practice. So CPAP first. Most of the time, CPAP should be sufficient. In a stable OHS, without a severe OSA, that is predominantly hypoventilation phenotype that was picked up in your level 1 sleep study, in such cases, NIV should be given upfront. For a stable OHS who has failed CPAP, or that is, there is persistent hypercapnia despite your first line CPAP, then switch to NIV. In acute hypercapnic respiratory failure, that is your unstable OHS, that is you have an underlying OHS that is going on and you have a pneumonia or a heart failure on top, so you give BiPAP plus oxygen. That is what we do in our ICUs most commonly. And when the NIV fails, obviously you are left with no choice but to go for intubation and mechanical ventilation. Just to touch upon the other modes, we have hybrid modes also. So these are all modes available on your small NIV machines. So AVAPS mode is a hybrid mode, where it is a volume assured mode. It maintains a tidal volume by adjusting the IPAP. So the EPAP is kept same, the IPAP is adjusted as per the AI algorithm, and the desired volume is always delivered. What is IVAPS? IVAPS is similar to AVAPS. This is also a volume assured mode only. So here the difference is that the EPAP also varies and the IPAP also varies. So there is an auto-titrating expiratory PAP, and it maintains the upper airway patency and it improves patient compliance. So what are the other measures? So other than the PAP devices, there is obviously role for a sustained weight loss, bariatric surgery, but we don't recommend that much for weight loss to begin with, because there is a lot of complications that can be associated with it. Of course, the newer drugs, we have a session later today on the newer drugs for weight loss. Then tracheostomy obviously eliminates the upper airway, the pharyngeal part completely, so it helps to improve OSA. And it is reserved for patients failing all modalities of PAP therapy. What are the drugs that can be tried? Acetazolamide and medroxyprogesterone are two drugs that can be tried. They induce metabolic acidosis and they increase minute ventilation. But the bad side is, when there is an increased respiratory drive, this also exposes the upper airway to an increased intrathoracic negative pressure. So that in turn can also promote your upper airway collapse. So you have to be very cautious while using all these drugs in extremely obese patients. The role of isolated oxygen therapy, like I said, isolated oxygen can be detrimental in stable OHS. It can worsen your VQ mismatch, it can precipitate decompensated respiratory failure, it can worsen the Haldane effect. So giving oxygen alone is futile, so always give oxygen with NIV. Then common errors like overuse of supplemental oxygen, overuse of loop diuretics, and diagnostic confusion with COPD. So in the definition itself, the OHS defines, the other causes of hypoventilation, such as neurological cause, the uses of drugs, COPD should be ruled out. Then only we can label the patient as pure hypoventilation. Just a slide on screening and perioperative management. So screening should be done with looking into the serum bicarbonate values and the pulse oximetry. There is high risk of OSA if the SpO2 is less than 93 and if the serum bicarb is more than 27. It is low risk if the SpO2 is more than 93 and bicarb is less. Once the ABG confirms the elevated PCO2 levels, OHS is confirmed or OHS is ruled out. If confirmed, we must always assess for cor pulmonale, that is features of right heart dysfunction. And we should try to optimize the underlying etiology or the underlying conditions as much with PAP therapy before proceeding to surgery. So this slide comprehensively shows the effect of PAP therapy and multimodality therapy such as exercise, positional therapy, drugs and everything on the parameters such as blood pressure and other metabolic components. So like how you can see, PAP therapy alone does help in decreasing the comorbidities, but when you combine it with the multimodality approach, you can clearly see that it gives a better outcome. So just to conclude, a delay in diagnosis increases morbidity, mortality and cost of care. Screening with a blood gas analysis, which will give you both the carbon dioxide and the bicarb. Level 1 PSG study to look for hypoventilation. You add your level 1 PSG study, you do your ETCO2 monitoring also. That will give an estimate of the carbon dioxide levels. And PFT, the spirometry plus DLCO to rule out or rule in COPD. ECG plus 2D echo to demonstrate the right heart complications. And like I said, CPAP works for most patients. Non-responders switch to BiPAP. That's all. Thank you.
Thank you, sir, for the wonderful presentation. I would like to request Dr. Kinjal Modi for the felicitation of the chairpersons and the speaker.
Bhumika, question answers for Arjun. So the topic is quite vast. We, as a different faculties, apart from the pulmonology, we usually know we know only basics, but he has covered A to Z, very detailed lecture. I think you people must be having some queries. If you have any queries, you please ask him now.
Mike, ma'am has. So that depends on patient to patient, ma'am. We have seen patients that have required an IPAP as much as 30. Normally in a ventilator, we don't go about 26 or 24 because the EPAP 6 is always there. So, but in clinical practice, up to 30 also we've gone. Everything depends upon your transpulmonary pressures and the transpleural pressure. So since obesity is a major factor, the lung expansion for it to occur, there are, that is the importance of getting a proper titration. So once the titration is done, when we slowly, gradually step up the IPAP by 2, then we can adequately titrate and prevent volume trauma.
So I think it's a multimodal approach rather than going after one approach. No? So the patient most of the patients will, get better with CPAP.
Majority of the patients, because OSC is the primary component in OHS also. So they get better with CPAP.
If those people don't respond, then you put them for bi-level PAP with an O2 supplement.
Yes.
Okay.
Yes.
Right.
Yeah. Yeah. With time, only it will change. Like for instance, there is a time gap. That's what. CPAP is just part of treatment. Like I always tell my patients, you start this. Yes, it does. So it is part of treatment, but not just the treatment, right? So if you do everything together only, you will get a desired outcome. Yes. So if you do all three together, the outcome will be better. That's all.
Any other question? Okay.
Thank you.
Thank you, Arjun, for wonderful talk and clearing our thoughts.
Next up, we have our next topic. Beyond traditional sleep studies, the role of peripheral arterial tonometry in OSA diagnosis. Our speaker is Dr. Kinjal Modi, sir. Can we please also call upon the chairpersons, Dr. Vaishali Lokhande ma'am and Rajesh Matta sir, to take up and come up in the podium. Dr. Vaishali ma'am, MD Medicine, DNB Medicine, AFIH, Senior Consultant Physician at Apollo Hospitals, Navi, Mumbai, MD from Sion Hospital in 2003, 7 research publications in international and national journals, certificate course in AI in Medicine conducted by DRS Group. Dr. Rajesh Matta completed his DM in Cardiology from the prestigious KEM Hospital, Mumbai, followed He's MD in internal medicine and MBBS. He also has further enhanced his expertise through a fellowship in structural and valvular heart disease with a special interest in structural heart interventions, complex coronary angioplasty, pacemaker implantations, and device closure procedures. I'll also request the chairpersons to introduce the speaker.
Dr. Kenjal Modi, welcome. He is consultant pulmonologist, MBBS from Vadodara, MD from Nair Hospital, Mumbai, and DNB from Navi, New Delhi. He has done his FCCP from USA and trained in Spain as well. He's undergone interventional pulmonology training from Malaysia. Also has done a PGDMLS and PGDHHM from Symbiosis, Pune. He's also a lawyer with an LLM degree from business law in Mumbai University, and it is very tiring and I'm breathless to just read his degrees, Dr. Modi. I mean, just a round of applause just for these degrees, you know. He has been around for 2 decades as consultant pulmonary physician at Hinduja Hospital, Khar, and also Western Hospital suburbs like Suchak Hospital and Criticare Hospital, Malad, and several other hospitals in Borivali and Kandivali. He has special interest in asthma, COPD, lung fibrosis, sleep apnea, bronchoscopy, critical respiratory care, multiple publications to his credit. He is a marathoner, he's a singer, he's a poet and a YouTuber with more than 100 videos on his channel.
Hey, that's okay.
There is too many other things. Let's hear Dr. Modi woo us all with his knowledge.
Thank you so much, madam, for that introduction. But basically, I'm very humbled with that. The only thing is that while preparing the talk, I remember that madam and me both belong to the same alma mater, the Nair Hospital, JMJ madam batch. So, hardcore academicians. So, madam basically gave me a talk, and unfortunately, I was not planning to come because I had some other things already planned up, and then final moment it got cancelled, so I was happy to come in. But then I realized the topic was given to me was peripheral artery tonometry. Something new I heard. That is basically learning lesson for me also. But while preparing, I was telling madam that basically I also am learning that itna acha cheez hai. There's good thing that I have learned and I can explain to people now that basically apart from that sleep study what we have been doing for years together, polysomnography or a limited sleep study, there is a new thing which has come in the market and which is more kind of reliable also and can be used in a day-to-day practice and multiple times also. So we'll throw some light on it. But yeah, it's a new thing that I also learned and it's good for me that I came here. Thank you so much, madam. And for inviting here and all of you be here to listen to me on a Sunday afternoon. So peripheral arterial tonometry, that is something PAT, that's a short form I'm going to use from now onwards. Now, I bring regards from Hinduja Hospital. The basic outline of the talk is something about PAT, what is it and what is a home-based testing platform. It is a home sleep apnea test, HSAT, that is what been short form called for these things. How the reports look like, how to interpret a report in an easier manner, and final conclusion on what I have to say. So I try to complete everything within 15 minutes, as much time I can have for it. Okay, so simple explanation for the tonometry. It starts, yeah. So it's pointer, I'm not able to see. That's okay. So basically, आ रहा है यहाँ पे है उधर नहीं अच्छा ओह अच्छा oh thanks something this is what I came to Apollo to always learn new things, so that's good for me. Thank you. So this is that PAT what is a non-invasive technology to measure arterial pulse volume changes in the finger. So what is it, arterial pulse volume and all these things, I'll just tell you in the next few slides. In the obstructive sleep apnea diagnosis, the PAT devices detect the sympathetic nervous system activation, such as vasoconstriction and pulse amplitude drops that occurs at the end of respiratory events and arousals. So what is the diagnostic role overall of this study is, as I told you, it's a home sleep apnea testing, that is that HSAT, short form what I was using, and it has been endorsed by American Academy of Sleep Medicine. So it has been authenticated and validated also. The signals, there is a signal system, how it works and all those things, I'll tell you in few slides later. But there are some signals taken up from the fingers, that the arteries over here, and it is sent basically across to the machine and the report is generated. There are some metrics, how it comes at RDI, AHI, how they are calculated in this. Also, I'll tell you sometime. And validation, as I told you, it has been validated and 90% correlation with the PSG. It was something new. I was amazed to know that PSG has many wires around you. I think so. In the morning, people have sitting over here must have known that sleep study. What we do, there is a wires over the head, over your chest, over your legs, over your arms. So you feel like what you call a wired man during the sleep. Many people could not sleep during the night time because of these wirings most of the times. And this is a simple thing that can be done and at 90% correlation with the PSG machines. So advantage, obviously home convenience, we can do at home. We can give the machine to patient and that patient can do at home and easily can come back and give us a report. एक दिन नहीं हुआ दूसरे दिन भी कर सकते हैं. So it is cost is not a big problem because PSG, if you repeat, it is generally about 10K or 15K costing is there. So repeating there also is a financial issue. But repeating PAT is very easy. It's a small tonometer machine, so it can be easily repeated multiple times also. And research efficient, basically it's cost effective alternative to any patient who are a laboratory PSG. There are some limitations also. We have to understand that even differentiation many times is not very clear, that it is hypopnea or it is a rara or it is central or obstructive sleep apnea. Sometimes there are issues because it is a machine interpreted test, manually can be checked also, but there are a few even differentiation issues. Clinical context, basically the PAT is primarily intended for patient who has a high pre-test probability for moderate to severe sleep apnea already. They are mainly made for this kind of patient, not for all patient to diagnose like mild or something like that. And false negative are possible in mild cases. That is what they have said. In complex or mild cases, you might have a false negatives also. Okay. So now coming to the test part of it, it gives all, the first part is giving all the ticks over here. Yeah, there are 3-4 things. For you to consider only this PAT and oximeter. So PAT is basically that hypnogram. That is a graph we have been telling since morning. There is a RDI also can be calculated. It is a central sleep apnea or obstructive sleep apnea can also be noticed with the help of PAT. And positioning, means it is a supine OSA or a lateral OSA or position related OSA can be easily picked up with this. With oximeter only we can see the hypnogram, means basically only see the desaturation part of it. We cannot have the RDIs or RARAs, we cannot have the central or obstructive sleep apnea differentiation or the position part of it. That is the thing you have to understand. So one more thing, more differentiation compared to pulse oximeter is everyone knows about. I think so after COVID everyone knows how pulse oximeter works. It works on 2 things, oxyhemoglobin and deoxyhemoglobin. Both the wavelengths are calculated and depending on that the saturation is given to us. So if both the waves, as you can see, they both are different waves, and that is why they produce a different width of the amplitude also. So now this PAT signal is only one wave. It is measured, the signal. PAT signal is from here to here directly, from the top of the nail to the bottom of the nail. I have another slide also showing exactly how it works. And for SpO2, generally it is from the nail bed, from here to here it measures. So basically this only here to measure saturation. But PAT, along with the saturation part of it, it has basically to work with the tonometer. That is a machine which is how it's fitted on the finger. So going more detail about it, the amplitude of the SpO2 generally changes with the oxyhemoglobin and deoxyhemoglobin. You can see that basically the hemoglobin, where the wave changes, where the patient blood is oxygenated, the wave is larger, and when the wave is not oxygenated, the wave is smaller. The amplitude changes with the oxy and deoxy itself. But tonometer basically does not have that kind of issues because it is measuring only at one wavelength. So only one reading will be there. So authenticity is more with the PAT. Now, just to understand how it works, you just show your finger. This is like a small machine. It gets fit inside. It pushes my finger. It almost closes my finger. So basically, no external pressure comes out. A small pressure inside, and then it starts measuring the arterial pulsation inside my nail, from here to here, from this way. So basically, it's shown in the figure over here. So it measures the tonometer over here. So arterial constriction and arterial dilatation is measured. Now, what does that do? So basically, this is normal artery, and when it is pressurized, this is the tonometer, this is the amplitude which is going to measure by the machine. So this word is very difficult for me to spell, unfortunately. And simple thing is polysomnography to understand, and uniform pressure fields. Finally, that gives us an idea that the peripheral arterial tonometry signals increases, and there is cancellation of noise signal also, because if it is pressured from outside, then there is no external pressure on the thumb or a finger, basically. So outside pressure is not going to affect. So noise cancellation, as we use in our advanced Bluetooth, the same fundamental is used over here. So pressure around the whole finger, so no pressure from outside, so noise cancellation. And inside pressure tonometry, as I told you here, is measured across the finger. Till now, things are bit crazy for us. Basically, अभी तक इतना समझ में नहीं आता, be very frank. एक दो slide और समझ में आएगा. How the machine looks like. So there are three parts of the machines. One is a chest piece. The chest piece basically measures the snoring part, body positioning, and the chest movements. There is a wristband. So basically that is the actigraphy, basically that is picked up by the wristband. And the main tonometer machine, which is fitted on the finger, that measures the PAT, that is the tonometry, oximetry, and the heart rate. Three things are measured over here. So total, basically 3 contact points and 7 monitor signals are there with the PAT. Now the basic understanding, science behind the PAT, that is what we understand in this slide. So we all know that when the person is in sympathetic activity, the heart rate increases, right? So when heart rate increases and vasoconstriction also occurs simultaneously. These 2 points are picked up easily with the PAT. So this is the thing, it is studied and noticed, and the graph are formed on this basis. So during the sleep apnea phase, we know that sympathetic activity bit goes up. Same thing happens during REM sleep also, but how we differentiate we'll see later on. But this happens that when sympathetic activity goes up, the tonometer that picks up that activity because of vasoconstriction. Now vasoconstriction, how it picks up? Now you see, this is the amplitude when the vasodilatation is there. Moment vasoconstriction starts occurring with the sympathetic activity, the amplitude goes down. So the machine understands that now vasoconstriction is occurring, right? Because lesser the artery, the less will be the amplitude form. Understood that way. Okay. So when the normal blood flow is there, it is this amplitude. When vasoconstriction is there, it is this amplitude. So depending on which sympathetic activity, basically autonomic activity, autonomic nervous system based test in short. Okay. So unique PAT technology provides us an accurate, compact, unobstructive and easy to apply home sleep apnea test, accounting for lower failure rates in clinical operations. That is, first part is clear now. Something about the report, how it looks like. Okay, so the report looks like this. 3-4 things easily picked up. First part over here gives the summary of the sleep timing and all those things. That is easy, we know with all the report gets. Next is the indices, what are the RDI, AHI, all those things are picked up easily over here. Second part over here is picked up is the saturation and pulse information, that what is saturation, what is desaturation, and what is the heart rate statistics. Last is a graph over here, that is hypnogram, and the trends over here, which gives a clear idea of the respiratory events, snoring, body positioning, SpO2, and the sleep weight cycles. Now, how does this report is, which is basically gives a very fantastic view of, saves time, and it is a artificially generated report. But how does this report, how we interpret this? Now, seeing the report one by one, these are all the 7 parameters which are measured on the left hand side is measured over here. These are all the ictigraphy, all the positions, and all these things are measured on the machine. Now, you see A, B, and C, 3 parts are there. First and third almost looks okay, but thing is, you can see the PAT. We have to see, concentrate on this part. So there more amplitude is there, here amplitude is reduced. Here amplitude again is on the higher side. So this is the vasoconstriction phase, as I told you. When vasodilatation, the amplitude is more, and when vasoconstriction, amplitude less. I'll go just tell you this one, yeah. So we have to just concentrate this part, vasoconstriction, vasodilatation. So same thing is picked up over here, and the derived PAT, again we can see that amplitude has changed compared to over here, both the sides. But simultaneously, if you see the pulse also shows a great variation. So this actually is the REM sleep. This is not anything abnormal. The NREM and REM sleep is picked up easily like this. And this is a small wake-up cycle, wake-up phase over here, or else basically things are normal over here. Same thing can be picked up on everything, but the whole report is ready. It looks like this. And I'm just going a bit faster because in the context of time, but thing is, each and every slide can be explained very detailed later on, but I'm waiting only where things need explanation. So the similar thing as I told you, this is the REM part, the same graph which I have seen on the polysomnography, the same graph we can get with the PAT also, right? These are the REM part of it, and this is the REM related snoring, because in REM we know that the tone, muscle tone goes down and the tongue falls back, and this is a snoring. We can clearly see over here the SpO2 has dropped a lot, and the snoring also has come up during this time. Okay. Now, though, what does the machine do actually is, it sees the apneic events are terminated throughout the sympathetic arousals. All the apneic events are related to the sympathetic arousals. So that is picked up with the help of the PAT. And there are detected from the two physiological changes, that is arterial volume and the heart rate. So arterial volume goes down when the concentration is there, and heart rate increases when there is a sympathetic activity. So these two are picked up. And last but not the least, along with saturation drop, with desaturation, with vasoconstriction and increased heart rate. So all these three factors gives us a idea. And how the things further progresses, the flow is low. There are micro arousals are there. Along with desaturation, or there is a ventilation, which is basically snoring effect also is there. This all is picked up in the sleep-related breathing disorders, either central or obstructive. Okay, and here also we can get a AHI index, which is the sleep-related breathing events and the total time over it. And this also gives a clear AHI, and the classification of AHI we already discussed in the previous lectures. So easy is that tonometer is applied, a report is generated, and it is verified basically with the person who is seeing the report, and can be discussed with the patient. So now these are just a few more, 4 or 5 slides more, just to give you how the picture looks like and some examples. This is the raw signals, how it is picked up. Manually also we can exactly monitor the things, and we can see these are the respiratory events easily picked up on the PAT machine. REM, basically obstructive sleep apnea and central sleep apnea, can also be easily picked up. We know that difference, that movement is there and not there during the central sleep apnea, can be easily picked up with the PAT reports also. So apnea, hypopnea, RERA, everything can be measured with the help of this. Central sleep apnea, chain stroke respiration, again can be picked up with the help of PAT. So whatever we can do with PSG can be done with the PAT. So it's a very nice, simple thing, and easily reproducible things can be done with the help of PAT machines. So sleep apnea, central and obstructive respiratory events are automatically scored and easily recognized and manually editable also. One more thing which I was astonished to understand, to know about, is something called arrhythmia detection also, because it measures heart rate also simultaneously. So even arrhythmias are picked up, premature arterial beats or the atrial fibrillation. So basically it automatically flags the common arrhythmias such as premature beats and atrial fibrillation during the tonometry report. So good for a patient who have cardiac events simultaneously. These are the various meta-analysis of various studies has been done for. This is not one information just coming across. It has been studied and nicely been documented in various journals from 2000 onwards till date, and various papers are also published for this, the same thing. So watch PAT, or the peripheral artery tonometry, is a well-validated, accurate instrument for diagnosing sleep apnea. There is structured approach for scoring and review, as I told you, which are basically one by one how to go about it. So there is a person basically sits around, sees all the waves and calculates finally manually editable also. So basically finally AHI, as we do manual reporting of PSG, same manual reporting of pH also can be done. So last slide, basically it is the PAT is a home sleep apnea test. It is generally compact, non-obstructive and simple to apply, accounting for low failure rates in clinical operations. Automated report saves time and basically easily scalable on operational efficiencies. The automated hypogram is, hypnogram is easy to verify and edit also if you want to do it. Central and obstructive sleep apneas can easily be automatically scored on it. And last but not the least, is a potentially powerful and a well-validated and accurate instrument for diagnosing and characterizing the sleep apnea. So this was all I learned, and I wanted to share with you regarding the PAT. If you have any doubts, if I can answer, I will be happy to answer. Thank you so much.
Thank you, Dr. Modi. Very complex topic, and he tried to make it as lucid as he could. I'm sure many of us must still be having a lot of questions. I have one question for you, sir. Does it matter if the patient has any peripheral vascular disease or a diabetic
Then it's
dysautonomia?
difficult, madam. It's
Does
limitations.
does the pad become valid in those cases?
But peripheral vascular disease, generally the lower limbs are mostly involved. But yeah, in diabetic and all those things, upper limb definitely can be involved. We cannot say no for it. So if they are, we know if it's a PVD, then better avoid tonometry in those patients, madam. Then you go for the actual PSG, better, madam, for that.
I had one question.
Yeah, please.
So what these patients present to us as cardiologists, they come with hypertension.
Right.
Most of them, they are uncontrolled hypertensives.
Right.
So when we start them on drugs, specifically drugs which are blocking the sympathetic system, is this still, like if we give an alpha and
Then it is
like
difficult.
then it's a...
Yeah, I understand, because it is based on autonomic nervous system detection, and depending on that. So if it is affecting it that badly that it is not able to pick up the things, then not issue. Because just give it a trial, because it is a very simple thing, a small tool given to patient. आप घर पे देख लो, कर लो, and come back to me with the report. अगर positive आ गया, good luck for you. If it was not, then PSG obviously is there for answer to your questions. Thank you for your question. Any other doubts from audience if someone has? Cost, madam, I have to just see, and basically, but it won't be, I think, so very costly. In India, it is not, it is just foreign things available. In India, sorry, this is my phone, I think. So, yeah, it's my phone, just switch it off, dear. Sorry. So, in India, basically, what we have is that oximeter is easily available. It can be used as an oximeter, also can be oximetry, as I told in the initial part, have their own graphs, and for that, they are trying to get it through the cloud that compared to other people, we can give a report. So there's a new thing which is coming up in the market, but it is not tonometer, it is oximeter only. So PAT is yet to be in the market. Yeah, so basically that is a new thing which has come, the iPhone watches and all those things they picked up. So even iPhone has now very nicely picked up ECGs, and pulse oximeter is visually picked up. But all watches, I'm not sure about it, madam. The common watches which have come up with the wrist, how accurate they are in those things, they are a good tool to tell you that something is abnormal. If they are, please go ahead and get it checked in a better manner, because the technologies which they are using at present are still, they themselves are learning. So it is not that everything what they are doing is perfect. They are getting the ECGs on the eye watches nowadays, or basically heart blood pressures are also measured on just on the watch. So they have a wristband blood pressure monitors nowadays. That is a good thing. But how accurate they are? That's what. Actigraphy, yeah, madam. For actigraphy, it is really good. Right. For circadian rhythm, for your throughout the day, what is your desaturation, all those things can be easily picked up over there. Nocturnously. Throughout the day, basically, nocturnal, diurnal variation, everything can be picked up, madam. That's really good. Yeah. But the only thing you have to wear the watch 24/7 then. Right. Anything else? Yeah. Thank you so much. Thank you.
Good talk. Thank you, sir.
Thank you, ma'am.
Thank you, sir, for making this complex topic a little bit easier. I would like to call Dr. Prachi ma'am, Prachi Sankhe, to please felicitate the chairperson and his speaker. Next up, our topic is personalized treatment of OSA. Where do MADs fit in? Our speaker for the topic is Dr. Avinash Shar. The chairpersons, Dr. Tulika Diwan and Dr. Ninad Mule. I would request them to come up on the stage and take the podium.
नहीं करेगा वो कनेक्ट ठीक है आप नेक्स्ट ले लो फिर देखते हैं बड़ा है ये तो नेक्स्ट ले लो तब तक मैं पिन ड्राइव डाल ऐसा करो बड़ा आपका नहीं बड़ा है एक्चुअली इट विल टेक टाइम पीछे एक मिनट यहाँ से ये दोनों से ऑपरेट मैं इसमें डाल के क्या डिटेक्ट नहीं मैम आप नेक्स्ट स्पीकर को ले लो टाइम पे तब तक मैं डाल के
या तो फिर लंच रख देते अगर लंच रेडी तो लंच करा देते फिर कर देते
एक मिनट में मुझको देख रहा हूँ खाली अपोलो हॉस्पिटल CME तो बोला था
We'll just start the lunch now and we'll assemble again in half an hour. Then we'll restart.
Sound शायद नहीं है. They're operating from there. Can we start? I'm requesting everyone to gather in the auditorium. We'll be starting our next session. Our next topic is personalized treatment of OSA. Where do MAADs fit in? The speaker for the topic is Dr. Avinash Shah, the chairpersons, Dr. Tulika Devan and Dr. Ninad Mule. Let me introduce the chairpersons and I'll request the chairperson to introduce the speaker. Dr. Tulika Devan, consultant oral and maxillofacial surgeon at Apollo Hospitals, Navi, Mumbai. Her work focuses on maxillofacial pathology, trauma and facial aesthetics. Dr. Ninad Sharad Mule, BDS MDS, is a consultant prosthodontist and an implantologist with over 13 to 15 years of clinical experience. He completed his BDS from Manipal College of Dental Sciences and his MDS in prosthodontics from Government Dental College.
Good afternoon, everyone. For the post-lunch session, it is my privilege to introduce the speaker for the next session, the topic of which is personalized treatment of OSA. Where do mandibular advancement devices fit in? I would like to introduce Dr. Avinash Shah, a distinguished academician, clinician, and implantologist with over 20 years of experience in oral medicine and radiology. Sir has done pioneering work in temporomandibular disorders, in occlusion therapy and implantology, for which he has been credited with various awards. He's also been invited at various conferences as speaker, and with his latest research into sleep medicine, he will be presenting the next topic. Welcome you, sir.
Good afternoon, everyone. Thank you for the nice introduction. It is a post-lunch session, and I think you will feel sleepy in obstructive sleep apnea. So, just a joke. Okay. So, good afternoon. So, I welcome you all for this sleep medicine clinic at Apollo Hospital. I congratulate all the staff for this inauguration and starting their clinic. So, you know, dentists are not only doctors for teeth and the gums, but we are also physicians of the masticatory system. So, the masticatory system starts from, you can say, joint, teeth, muscles, and the ligaments. So, whole structures are there. Okay. So, there are the TMJ and the obstructive sleep apnea or airway are the new verticals of the dentistry. So, medical practitioners and dentists work together for the oral or obstructive sleep apnea management. So, there is a lot of sleep specialists are there in the medical faculty, and a lot of specialists from the dental faculty, we require to manage the sleep apnea. Okay. Why it is important for us to know about the airway? So, does dentist play a role in the OSA? So, OSA patient may not come directly to the dentist, so need to screen each OPD patient for OSA and a TMD. So, whichever the patients are coming to our dental OPD, we need to screen for the obstructive sleep apnea by some questionnaire or by doing clinical examination. If you are going for any major treatment like bite changes, like we do in case of full mouth rehabs or orthodontia, so then we need to rule out the pre-existing OSA in that patient and airway also. If any of the old patient is having the repeated fracture of the restorations and failure of the implant and implant restoration, pain in the orificial area, TMJ region, need OSA or airway or TMJ evaluations. Okay. So though it looks like a medical problem, we dentists have a lot of role in the prevention and management of OSA along with the medical OSA specialists. So this was in just recent conference at Mumbai. It is an international sleep conference. I attended that, and then one speaker talked about this, the clinical phenotype of the Southeast Asian temporomandibular disorders patients with upper airway resistance syndrome. So TMJ and airway, they are very close relationship. Okay. So as a dentist, we examine this oral cavity and we look for the intraoral various anatomical parts like the tongue, tongue, uvula, palate, and this is very important for us. So there are the airway starts from the nose, it goes to the pharynx, oropharynx, and down also. So we as a dentist, we should concentrate on this area where the tongue is there. Okay. So tongue space is very important. If the tongue doesn't get a proper space, it will fall back, and that will cause the obstruction in the oropharyngeal area. Okay. So red flags patient for dentists are the reduced tongue space and backward position of the mandible. So where the situation is if the mandible is like this, we say it is a class 2 malocclusion we say, in that the patients are more prone for the sleep apnea because there is not a sufficient space for the tongue. And also as the age changes happen, attrition of the teeth happen, again the space for the tongue reduces. That's why after 40s, patient develops sleep apnea, obstructive sleep apnea. So this deep bite, so this is a deep bite patient, if you see in the OPD. So here you cannot see the lower teeth. Okay. So these are the deep bite cases. They are the prone for the sleep apnea. So normally we follow the method, Shimbashi method, where the upper and lower, where the upper and lower teeth distance should be this 18 millimeter. From the upper gingival level to lower gingival level, at least it should be 18 millimeter or more. This type of the patients are also prone for the sleep apnea, these deep bite cases. So this patient will develop later on in their life. These cases, you can see the lot of teeth problems are also there. And failures of the prosthesis is there due to this. This here's a gap in the front teeth and the mandible is going back. So in the TMJ also, if the slip disc happen, the area for the tongue reduce as the jaw go backward like this here, and it affects the posture of the patient also. So in this patient, bite issues are also there. The bite force, there is a discrepancy in right and left side. So it affects the bite of the patient and the forces. So in TMJ evaluation, what we need to do, we need to check for any sounds are coming from the joint, like a slip, we called it as a clicking in the joint, and that is a diagnosis for the slip disc. Then patient is deviating the mandible to on one side. So this is a TMJ problem, the patient is having TMJ problem. Then these are the different situations where, can you run the video first? So first video, this is the normal TMJ, the normal disc is there, okay?
So you can see bow tie appearance of the disc on mouth opening, there is a normal disc. And the second situation, where the disc is anteriorly displaced, okay? So here in this situation, the patient get reduced vertical dimension. Just play the second video.
In this device, disc is anteriorly displaced.
Sound is there. Okay, so we need to rule out. We need to rule out the TMJ status of the patient also, and then it goes advances. The patient also if the disc displacement happen, then the next level is the osteoarthritis of the TMJ. That again reduce the vertical height of the teeth. You can see this is 22 years old female with a TMJ osteoarthritis, and she was having history of the clicking 5 years back. You can see here on the OPG, right side the joint space is nearly normal, and the left hand side there is no radiographic joint space. So this was the osteoarthritis on the left hand side, this is the right hand side. Okay, so again this will affect the tongue space. So play this video. How the TMJ affects the airway. So if the patient does bruxism, that reduces the teeth height and it affects the TMJ and that reduces the tongue space. Okay. And this leads to the spasm of this muscle and tongue muscle, supraoid group of muscle, and that elevates the tongue. That is also cause for the reduced tongue space. Okay, now this is very important video, why nasal breathing is healthy, and if the child is not breathing through the nose and if they are breathing through the mouth, it will affect the whole structure, orofacial structure, the tongue position, everything. Just play this video. This we call the child OSA.
The normal or physiological way of breathing is through your nose. Breathing through the nose permits to purify the air by the structures inside the nasal cavity. In that way, the air entering into your nasal and oropharynx, your throat, is not going to heavily affect the lymphoid tissue in the adenoids and tonsils, which is the last barrier to catch harmful particles in the air before it reaches your lungs. Besides clearing the air from harmful particles, nasal breathing stimulates the production of gases and substances in the nose, which are going to facilitate the entrance of the air to the lungs and prevent infection in your respiratory system. Mouth breathing allows the air to pass directly into your throat, where the adenoids and tonsils are located. In that way, the air entering into your body through your mouth has not previously been purified, and the lymphoid tissue in the adenoids and tonsils become the first defensive barrier against the harmful particles contained in the air. As a consequence, that lymphoid tissue overgrows, occupying a large volume of your throat. That makes more difficult for the nasal breathing, and you make a habit of breathing through your mouth. In order to breathe through your mouth, your lower jaw has to come down, as well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way, and so the tongue is able to rest on your palate, stimulating a normal growth and development of your upper jaw. Conversely, when you breathe through your mouth, your tongue has to descend and protrude. At the same time, the pressure of your cheeks increases, pushing the upper jaw inwards. So the growth and development of your upper jaw is negatively affected, resulting in an narrow and high palate. The upper dental arch requires a V shape instead of being a rounded dental arch. Therefore, your teeth do not have space to properly align. This also produces your upper and lower front teeth do not touch when you close your mouth. All those dysfunctions, mouth breathing, incorrect tongue posture, open mouth, and incorrect swallowing are going to continue affecting the growth and development of your upper and lower jaws. And as a consequence, there is less room for your teeth and they become crooked. Remember, the nose is for breathing and the mouth is for eating. Breathing through your nose and keeping your mouth closed with your lips together is going to help your upper and lower jaws to grow and develop better. But more importantly, it makes you healthier.
So you have seen this video. If the child is breathing through the mouth and they have a narrow jaw, then they are the obstructive sleep apnea patient from the childhood. And then everything, their health and everything of the patient will be affected. So if we diagnose this patient early, we can do means we can change the growth pattern of the jaw, we can expand it, and we can make them normal one and healthier also. So what happened, if the narrow upper jaw is there, it will narrow down here the base of the nose also. And the patient will get recurrent nose infection, throat infection. So we can detect them early. So if the patients are coming to the dentist or to the pediatricians also, they can note down these things and they can accordingly do the needful for the patient. Okay. So OSA etiological factor, first we can say nasal obstruction, maybe polyps, septal deviation, tumors, trauma and stenosis, or retropalatal obstructions or the retroglossal obstructions are there. There are many other factors are there, but we are more focused on the as a dentist, retropalatal and the retroglossal obstructions. So when you sleep, what happens? So if the tongue is going to fall back, then there is a difficulty in the breathing. So there is no breathe is going down. So it may be, we can say hypopnea or apnea is happening. And how to diagnose the patient is maybe having or prone for the sleep apnea. This is the Malampatti classification is there. So just ask the patient to open the mouth and just check for the soft palate and the uvula. So if you are clearly visible uvula and the soft palate, that is class 1, then tip of the uvula is visible, that is class 2, and the soft palate and the base of the uvula is visible is class 3, and complete uvula is not seen and the lower part of the soft palate is not seen, is class 4. So class 3 and class 4 patients, they are more prone for the sleep apnea, or you can ask them the history also. Okay. And then relation between the tongue tie and the sleep apnea. So there are several ways a tongue tie can be contribute to sleep apnea. The tongue comprises 8 muscles, of which all of which are vital for the function of swallowing and maintaining a posture of the neck and the shoulders. It also plays a role in breathing and keeping the back of the tongue resting high on the palate. So tongue should be always rest on the palate for the growth and development and rest of the time also. So it helps the airway wide open. In rare cases, the tongue rests low because of the tongue tie. So tongue tie is there, then the speaking issues are there, and the swallowing issues are there, breathing issues are there. So low tongue muscle tone, mouth breathing, or inadequate space in the mouth, this can lead the back part of the tongue to fall behind the narrow airway, causing airway function disorder. Airway function disorder includes noisy breathing, snoring, mouth breathing, URS, sleep apnea, and the oral muscles dysfunction in the children and the adult. So this is the first one, is the normal tongue posture. Okay, second, you can see here, the tongue tie is there. So due to tongue tie, the tongue is falling back. It is not touching to the palate. The moment you remove the tongue tie, again the normal functions, so normal tongue functions come back. Okay. This you can see here, tongue tie. जी first वाला video run करना. First and second one. So you ask the patient to just open the mouth wide open and ask the tongue to touch to the palate. Okay. So tongue tie is there. So you can see this heart shape appearance. So this is great for tongue tie. Along with the tongue tie removal, you need to ask the patient to do some exercises we call myofunctional exercises for the tongue. Ask the tongue patient to touch the tongue to the palate and do the tongue suction. Then some lip competency exercises, okay, are there, okay. So how do I proceed if the patient is coming to my practice? So first I take a case history and some questionnaire for the sleep apnea and the TMJ, clinical examination. We can do CBCT airway assessment because directly if we ask the patient to go for a sleep apnea, they will not go or they will deny it. If you have something to show them, they will go then. Okay. Then consultation with the ENT or allergy specialist, depending on the patient are having the problem, and to the sleep physicians also. I take the two, suppose in the CBCT I feel there is a narrow airway, then I take the 2 bites of the patient, one in a normal position, one is a mandibular anterior positions, we called as a mandibular anterior device for the device, and then I check on the CBCT, the airway is improving or not, okay? And then send the patient for the CBC. After the report, I plan the appliance and airway evaluation again after 4 to 6 months. Okay. If the sleep physician sent for the sleep study, depend on the sleep study or polysomnography report or AHI index, whatever they suggest, so we give that treatment to the patient. And then along with that, I also give the appliance to the patient, along with the CPAP also. It helps a lot. So these are the different mandibular advancement devices where the appliances are there, where upper jaw, lower jaw, and patient cannot take the mandible forward for a long period of time. So it is like a calibration of the appliance is always there. So slowly 2 millimeters, sometimes 4 millimeter, then 6 millimeter slide deck. So we need a calibration in the appliance. There are different appliances available for this mandibular advancement. Okay. And this anti-repositioning appliance cannot be given for a long time, because if the patient is having pre-existing TMD, it aggravates that and then it may cause the TMD also. So, and this appliance should be given at an orthopedically stable position so that it will less and less affect to the TMJ. So this is the anterior mandibular anterior repositioning appliance. This is a CAD appliance. Okay, here you can, the ramp is there on the back. So you ask the patient to take the mandible forward and there is a posterior ramp. So patient cannot take back the mandible. Then we need to also advise this, if you are doing tongue tie or to the tongue position, we need to advise the myofunctional therapy to the patient. The tongue position, touching the tongue to the rest of the, and rest to the roof of the mouth. Then balloon inflammation, improving the overall tone and the strength of the throat and jaw muscles. Then lip standing, holding a spoon or buttons with the lips. It is often used to support the orthodontic treatment and to improve the overall facial aesthetic. So these exercises, all the sleep patients we need to advise to increase the tonicity of the muscle. Airway classification. So this is a radiographic airway classification. So this is by the Dr. Ajay Nayak, and there's a grade like 0, 1, 2, 3, and 4. So depending on the space, so least space, it is there, least space on this airway. It starts from the posterior part of the, you can say, soft palate, and it comes near the base of the tongue. So 0 grade is if the space is more than 201 millimeter squares. So, and where the constriction is, okay, and that is a non-narrow airway. Grade 1 is 150 to 200 millimeters. It is a minimal airway constriction. Grade 2, 100 to 150. It is a perceptible airway constriction. Grade 3 is 50 to 100. It is pronounced airway constriction. And grade 4 is 1 to 50. It is collapse airway. Okay. So whatever the airway we take in a standing position, and whenever the patient sleeps, this airway is less than that. So whatever we see, always the airway is less than that. So this is, you can say grade 1, you can see here. The minimal area is the 164 millimeter square at the base of the tongue. Then this is grade 2, is minimum area is 129. Grade 3 is minimal area is 63, and grade 4, total black. So these patients are having a severe obstruction. Okay. We can also see the nasal obstruction on this CBCT. So these are the different grades of the airway obstruction on CBCT we can evaluate. Okay. Same way it is helpful for the treatment planning also. So this is you can say grade 0. This volume is 36 and minimal area is 419 millimeter. Okay, this is the case 1. So patient, this Saurabh patient was already on the CPAP and he was not comfortable. He was left wearing the CPAP because it was not comfortable, hurting the muscles and the jaw. And when I examined his jaw, he was having the crossbite, not stable joint position. So I given him the appliance. So this is not mandibular advancement appliance because this is a stabilization appliance. Again, the vertical height will increase the space for the tongue. And there are the certain things in the appliance that will reduce the forces on the muscles during the night times if the patient is doing bruxism or clenching. And in airway patient, there is a lot of things. On the sleep study also come to know the bruxism also patient is doing or not. And this is the bite forces, and the bite is also not equal on every tooth. It is uneven. And this was his airway. So you can see this is the close bite of the patient. So here you can see this is the constriction is 108 millimeter. And if you see there is no space for the tongue here, okay? Completely tongue is filled. And here we have given this stabilization. So we increase the height, so we getting some tongue space, okay? And airway slightly increase, okay? This is the anterior repositioning bite, and where again the airways increase 145, okay? And tongue space is increased. So the patient need both the appliances, but first we can start with that because the patient is having pain. So if the patient is having pain, we can start this. Again the pain will increase. So we have started with that, and again we can check after a month or 2 how much is the airway. ये आप वीडियो चलाओगे? वॉल्यूम तो So appliance will help the patient to increase the tongue space, increase the airway, and along with the CPAP, it becomes easy for the patient. So due to that pain, he was not able to wear the CPAP also. Okay, this patient where you can see the airway is 66 millimeter square, and this is with the lower with this stabilization appliance bite, and this is with the anterior repositioning. So we can just compare, but in both the cases, the tongue space, you are getting the tongue space. And then same time we take the TMJ also. So this is the closed mouth TMJ, this is with the increased bite. So see the TMJ position with the anterior position. It is come too much ahead. And then the TMD will increase, patient will have a head, neck, back pain also along with this. So we should not do. So what I advise, depending on the severity of the symptoms, I advise for 2 days of the TMJ appliance, 1 day of this repositioning appliance, or 1 day TMJ, 1 day sleep, like that. So it will stabilize the muscles also. So this was the bite of the patient. So this type of the bite, we can use the pattern resin, so dentists know. So the pattern resin is there depending on that CO bite and stabilization appliance bite, and this is the MAD appliance bite. So accordingly we send it to the civil city and to evaluate for the airways increase or not. And then we decide what to do. So same we can see here the stabilization split bite, and there is the MAD appliance bite. So that again the airway is not too much improved there. So then we decide not to go for that. We stick to the stabilization. Then this patient he was having already having the history of this heart issues, and he was already under the treatment, and we advised him the sleep study and everything, but he was not willing there. And then once we had done this CBCT airway analysis, we can see the airway is compromised here. Okay, then we just taken the bite and given the appliance to the patient where the increased airway you can see, and tongue space also. Okay, anti-mad appliance. But after 4 months, patient was not comfortable. After 4 months, he was complaining my pain increasing. So again we have, so this is anti-repositioning appliance, a trial appliance we can give. Okay, so again we have taken the CBCT. So here you can see 4 months after the upper anti-repositioning appliance, the airway is again decreasing. Okay, so we again take the stabilization splint bite and check. With the stabilization splint bite, the patient was comfortable and airway was also improved. Then we again given the stabilization appliance to the patient. Okay, so here you can see this is a pre-op. This is after 4 months. Now there is no appliance in the mouth, you can see. So still airway is good, and here also after 13 months, and good tongue space. If you compare the muscles here, they all are relaxed now. See, you can see it. So increase tongue space. Okay. This last slide. Okay, and the nose area also the swelling is reduced. Okay. And this patient, he was not having the airway issue. We treated him for the TMJ and the bite. And you can see his pre-op airway. And this is after with the appliance. And this is without the appliance. This is a good improvement in his airway. Okay. Thank you.
Any questions?
So excellent lecture, Dr. Avinash, and quite enlightening. I wanted to ask you, in your case studies, where have you noticed the maximum increase in oropharyngeal airway space, at the retropalatal or the retroglossal segments?
So retroglossal area. Even the retropalatal also, once the tongue come ahead, so that area compression on the palate area will decrease, and then it also comes ahead. So both the area it improve.
That's quite good.
So I have one question that suppose we have a patient with a severe loss of vertical dimension and a patient with no loss of vertical dimension. So is there any study which kind of tells us how much vertical dimension increase causes a significant increase in the airway space, or is it arbitrary?
One criteria is the Shimbashi, and second criteria we use the Willis measurement. So the distance from outer canthus of this should be equal to this. So I have seen many patients where vertical dimension of the teeth are good, but this facial measurement, there's a problem. Either they are having the class 2 or they may be a class 3 cases. So that time we need to evaluate, and accordingly we
Typically, how much vertical dimension do you increase in your regular patients?
So appliance patient depending on the Shimbashi. So suppose in some patient Shimbashi is 14 mm. So we can increase by 20 to 23 mm. So if the Shimbashi is 20, then we increase 2 to 3 mm of the previous space. So include that previous space into it, because patient is not having function. So in bite also. So you can increase by 10 millimeter without any problem. But it should be in an orthopedically stable position. So bite should be proper.
I have one more question. So we've seen all of these cases with patients with dentition. What about edentulous patients?
Edentulous patient is a tough job, but you can give dentures to the patient. Proper dentures with that particular height we can give it to the patient.
Any questions from the audience?
Okay, thank you.
Thank you, sir, for such an illustrative presentation and detailed one as well. I would like to request Dr. Kapil Iyer to felicitate the chairpersons and the speaker. Next up, I would like to request Dr. Bhumika Madhav to come on the podium for the presentations. The topics are pediatric sleep disorders, what every clinician should know, and obesity management and improvement of sleep disordered breathing. I would also like to request Dr. Prachi Sankhe to chair the presentation. Dr. Prachi Sankhe, MBBS MD, consultant physician and associate professor internal medicine specialist with over 12 years of comprehensive clinical and academic experience, approved postgraduate guide, author of several research papers published in indexed, peer-reviewed and national medical journals. I would also like to request Dr. Prachi Sankhe to introduce Dr. Bhumika Madhav.
Good afternoon, everyone. I would like to welcome my dear friend, Dr. Bhumika Madhav. She has done her MD Pulmonary Medicine from D.Y. Patil Hospital, Navi, Mumbai. She is currently practicing as pulmonologist and allergy and immunotherapy specialist, consultant at Apollo Hospital, Navi, Mumbai. She has also done her ASM Sleep ISR scoring course from American Academy of Sleep Medicine, a degree in pediatric sleep medicine, University of Colorado, and comprehensive sleep medicine course. I would like her to present and share some insight on the pediatric sleep disorders. Thank you.
Thank you so much for the kind introduction, Dr. Prachi. So, there are various sleep disorders that we see in pediatric age group. इससे पहला वाला. Behavioral insomnia of childhood is one of the most common problems that we see in day-to-day life. Along with that, sleep disorder breathing such as sleep apnea, parasomnia, circadian rhythm disorders, hypersomnolence disorders, and sleep-related movement disorders. These are the common things that we see in the pediatric age group. So this is my son. This is the first ever picture of him after he was born. He looks so cute, right? But he has troubled me so much when it comes to sleep. Every time I used to see a pediatrician in the ward, I used to ask him, इसको कब सोएगा, कब वो सोएगा, कब मैं सो पाऊंगी. So I have really dealt with all of this behavioral insomnia of childhood. This is him now. He's a little better, but still not perfect. So this was my halat every single night. In behavioral insomnia of childhood, they find it difficult to fall asleep. There are frequent night awakenings. There is bedtime resistance and stalling, and it is very common in infants and toddlers and in the preschool age group. But it can also present in the school age group, and it can present later on in life. So, behavioral insomnia of childhood has 3 common clinical patterns. The first one is sleep onset association type, limit setting type, and it can be combined. In sleep onset associated type, they basically require something to be done. Either the mother has to rock the child or they have to feed, something that they have to do every single time they wake up, and it happens frequently throughout the night. They find it very difficult to fall asleep. And in sleep onset association, basically they require rocking, feeding, holding, parental presence. They require similar toys. All of these things are needed. I had this problem with my son till at least he was 2 years of age.
Good night, Rita. Mommy, what are these? Mommy, bathroom. One more story. No, it's very late. Mommy.
So in limit setting type, child refuses to go to sleep. He tries to stall, he requests for water, one more story, cuddles, and it's very difficult for them to initiate the sleep. And caregiver provides, if the caregiver provides insufficient or inconsistent bed limit, that is when it happens. In combined type, the child has both the features, resistance as well as night awakening, and requires a parental presence to fall asleep. It is extremely stressful for the family and members of the house as well as the child. What happens if it is untreated? The child is irritable, he throws tantrums, there is mood swings, there is poor concentration, they find it difficult to focus on academics, there is fatigue during the day, there is low energy level, less active, less playful, and parents are also suffering. They are also exhausted and stressed, as well as the entire family is under stress. So what happens? The child wants something, the child cries, parent or the caregiver gives it to them, that child thinks it's a reward, and the sleep problem continues. And the child wants something again. So it's like a vicious cycle of behavior. So the core treatment principles include consistent schedule, same wake up and sleeping timing every single day, even on the weekends. Predictable routine. There should be a calm bedtime routine every single day before going to sleep. And we should encourage children to fall asleep independently. And the main thing is consistency. So there should be age-appropriate bedtime. For 1 to 2 years, the child requires at least 11 to 14 hours of sleep. For 3 to 5 years, the child requires 10 to 13 hours of sleep. For 6 to 12 years, they require 9 to 12 hours of sleep, and 13 to 18 years, they require 8 to 10 hours of sleep. So age-appropriate bedtime is absolutely essential. There has to be a fixed time when they go to sleep. By the time the child goes in the age group of 3 to 5 years, usually the naps, they stop napping during the afternoon time. Even if the child naps, they should try to nap earlier during the day and not towards the evening. And we have to be consistent with the routine. So what is the bedtime routine? So having a warm bath helps the child relax. A calm story just before going to sleep. Prayer, quiet time, unwinding, calm music, dimming of the lights in the evenings, and good nights, and then turn the lights off. So once you turn the lights off, you should not turn it on at all, and you should not give in to the child's tantrums. So there are various ways in which we can teach the child to have independent sleep. Extinction, which is a cry-it-out method. There is graduated extinction. Then there is parental feeding. In extinction, which is a cry-it-out method, you decide that you want to try it out. You put the child to bed, leave the room after the bedtime routine, and you do not return even if the child is crying. Unless and until the child is going to have any harm or safety issue, you don't respond to the crying or repeated calls. This method really works fast, but it is very difficult for parents to do this. The graduated extinction method, you first put the child to bed awake, and then you keep on checking the child at regular intervals. So example, you check at 1 minute, and then 3 minutes, and then 5 minutes, and so on and so forth. And each check has to be very boring. You don't have to interact with the child during that time. It has to be very boring. You just make sure that the child is safe, and that's all. In parental feeding, the child sits nearby first. After that, he sits by the chair, then the doorway, and then outside the room. So gradually, every single day, you go a little far away from the child, and the child is able to start sleeping independently. So, what are the practical parent tips rewarding good behavior? So, if the child has stayed in bed, you can give them stickers. If they fall asleep, you give them stickers, and you give them a pass. You give them up to 2 pass every day. That pass can be taken for water or washroom break. So, you have to tell them that you have only 2 passes at night. And if you want to use the washroom or do anything, you can use it only twice a day, twice at night. And the children, especially the older children, do really well with this method. So what are the red flags? If the child has loud snoring, excessive daytime sleepiness, significant behavioral or emotional concerns, chronic medical conditions such as asthma, restless legs, discomfort, pauses during breathing, any neurological concerns such as seizures, night terrors, developmental concerns such as autism spectrum, ADHD, any medications that could affect the sleep such as steroids or antihistaminics, or if the child is not developing, there's poor growth, failure to thrive, then these are the red flags and you need to consult a doctor. So coming to childhood obstructive sleep apnea, whenever there is partial or complete obstruction during the sleep which causes disruption, that is sleep apnea. Clinical features are loud snoring more than 3 days in a week, 3 nights in a week, witness apneas or gasping or choking, mouth breathing, nasal obstruction, restless sleep, frequent awakening, sweating, daytime sleepiness, irritability, poor concentration. In childhood age group, adenoid and tonsillar hypertrophy is one of the most common causes of sleep apnea. Other than that, obesity, allergic rhinitis, neuromuscular disorders may also cause sleep apnea. So why is it important? Because it affects the child's childhood. It can lead to poor attention, hyperactivity, difficulty in learning. It affects the mood of the child. It can lead to poor sleep quality, growth and developmental issues, and it can also affect the heart and cause metabolic issues such as insulin resistance and systemic hypertension, and it affects the quality of life. That affects the school performance, esteem, and the overall well-being of the family. For management, first we have to take proper history and examine the patient, do investigations. Polysomnography is the gold standard, and then accordingly assess the comorbidities and plan the treatment. If the patient has significant sleep apnea, then CPAP machine should be offered. If the cause of sleep apnea is adenoid or tonsil, then that should be offered to the patient. So depending on the clinical condition of the patient and examination, you offer the treatment. So mild, in childhood, AHI of less than 5 is mild OSA, 5 to 10 is moderate OSA, and more than 10 is severe OSA. This is different from what we talk about in adults. Coming to parasomnias, basically children getting tremors or sleep terror, sleepwalking, confusion, all of these usually happen in the first half of the sleep, in the non-REM sleep. And usually the child forgets about it. He doesn't recall it in the next morning. In nightmares, it usually occurs in the REM sleep, which is in the second half of the night. It is vivid and distressing, and the child even remembers about the sleep. It is more common after the age of 3. How do you approach a patient with parasomnia? First and foremost is to reassure the child's parents. You have to ensure safety. So you lock the doors, windows, remove any sharp or dangerous objects, guard the stairs, and use a safe sleep environment. And promote good sleep hygiene. Ask them to have a regular sleep schedule, adequate sleep duration, calm bedtime routine, and if there is any trigger, you identify that and then you treat it accordingly. If the events are frequent, prolonged, or injurious, then you have to evaluate it further. Delayed sleep-wake phase disorder. This is more common in the adolescent age group. Basically, because of the hormonal changes, the circadian rhythm of the body, it shifts to a later time. So even if you tell the child to go to sleep, he's not able to go to sleep. So how can you manage it? You manage it with a fixed wake time schedule every single day, including on the weekends. You ask them to go out in the morning, have a sunlight exposure, reduce the screen time. Screen time really affects the circadian rhythm. Gradually shift the bedtime earlier, every day by 10 to 15 minutes. And if required, melatonin can be given only if appropriate. So in hypersomnolence, children are excessively sleepy during the day. They find it difficult to wake up in the morning. They fall asleep in school or during quiet activities. They're irritable. They have a lot of mood changes. They are not able to concentrate. They are not able to recall anything. And there's a decline in their academics. Also, there is a lot of long daytime nap history. Causes could be poor quality sleep, sleep disorders such as sleep apnea, periodic limb movement, narcolepsy. It could be idiopathic. Neurological conditions such as seizure, brain injury, medical conditions such as hypothyroidism, anemia, obesity, psychiatric conditions such as depression and anxiety, and certain medications. So medications such as antihistaminics, antiepileptics, etc. So when I was in 10th standard, I had developed some rash on my body. I used to keep itching. I went to the dermatologist. He prescribed cetirizine to me. So ever since I started taking cetirizine, I used to sleep. I used to feel sleepy throughout the night. And my mom got really worried because I was in 10th standard. So it was because of the cetirizine that I was taking. And ultimately, the cause of that rash ended up being bed bugs. So for hypersomnolence, detailed sleep history is important. You screen for other sleep disorders, assess the medical, neurological, and the psychiatric history, do a thorough physical examination, and then advise appropriate investigations. Coming to the last part of the topic, sleep-related movement disorders, restless legs, restless nights. So sleep-related movement disorders are conditions where there is involuntary movement during the sleep or transition to sleep, which is disrupting the quality of sleep in children. So when there is restless leg, so there is an urge for the child to move the leg due to some uncomfortable sensation. It is worse in the evening or at bedtime. Think about low ferritin, iron deficiency, or a or significant family history or ADHD in such patients. In periodic limb movement, there is repetitive leg jerks during sleep, and the child may be unaware of the movement. It causes sleep fragmentation and causes daytime tiredness, and it is often identified in sleep study. Thank you.
Thank you so much, Dr. Bhumika. It was exceptionally high-yield and practical presentations. I think sleep in pediatric is not well given that much of importance because all the mothers, what I have come across, they always think that, nahi, I mean, 2 saal tak aise hi karega, aise hi soega. So ideal, what age group actually the mothers or the parents should look after this type
So you
of
can
sleep, age pattern?
You can start this after 6 months of age.
Acha.
6 months of age is when we can start trying it. So the cry-out method is very difficult for Indian parents specifically because we stay with our parents, grandparents. जैसे ही बच्चा रोता है कोई ना कोई घर में उठा लेता है.
Yeah, exactly, because that's the tradition.
Yeah. So in India it's very difficult to do that, but it has the best results. Other than that, the other 2 methods can be tried out after 6 months of age. That is when the child's sleep starts developing.
Right. So I think the sleep architecture, breathing pattern,
It all
and the
develops by
behavior,
about 6 to 8 months.
both are 2 different things, and that
Yes,
should be
yes.
early recognized because childhood obesity is also a great concern nowadays because
Yes.
of I think it's more of sleeping pattern as well.
Yes.
Okay. Any questions in the audience?
Ideally, yes, you should be doing, if the child is a habitual snorer, loud snoring more than 3 times in a week, then these patients should undergo a sleep study to look for sleep apnea, because even if the child undergoes a tonsillar surgery, it is better to take the treatment and then undergo the surgery. Yes, CPAPs are used in pediatric population as well. Thank you.
Thank you so much. Thank you.
Thank you, ma'am, for such a wonderful presentation. Next up, we have the penultimate session for the day, that is the panel discussion. It's a case-based discussion on treatment of sleep apnea. I would like to request the panelists to come up on the stage. Dr. Jayalakshmi TK, Dr. Srija Nair, Dr. Vinod Chavan, Dr. Kapil Iyer, and the panelists require no introduction. They're all eminent pulmonologists and clinicians in their respective fields. And sorry, one mistake from my side. I failed to felicitate Prachi ma'am and Bhumika ma'am. I'm very sorry for it. So ma'am, please come up on the stage and take your presence for the wonderful presentation, and the chairperson as well. Jayalakshmi ma'am, Dr. Jayalakshmi TK ma'am, please come up on the stage for felicitating Bhumika ma'am and Prachi ma'am. Two more chairs.
Hello. Welcome for the last session for the day, for the panel discussion. I would welcome my panelists, Dr. Vishal Gupta, who is a sleep specialist and pulmonologist practicing at Kharghar, also attached to Apollo Hospital, Navi, Mumbai, and Dr. Srija Nair, who is the head of department at MGM Hospital, Kamote, and also having her own private practice, very experienced pulmonologist, bronchoscopist, sleep specialist, everything. Dr. Kapil Iyer, who is our transplant pulmonologist, also pulmonologist practicing in sleep medicine, other aspects of pulmonology as well, but nowadays he focuses more on transplant, lung transplant, and also his favorite is to do podcasts with, he has very famous podcast and a good YouTube channel, Dr. Kapil Iyer, and Dr. Vinod Chavan. He is at Reliance Hospital, Kokilaben Hospital at Kopar Khairane, and practicing in Navi Mumbai since many years, also having his own practice at Panvel. He's now recently appointed as Joint Secretary of Indian Association of Bronchology, and he's worked a lot for all these conferences and the recent IIB conference in Pune. So welcome to our panel, and we will do a case-based discussion. So case 1, classic OSA patient which we see normally. So a 48-year-old male with loud snoring, witnessed apneas are there which the spouse has seen, excessive daytime sleepiness, morning headaches, poor concentration at work with known hypertension. BMI is high, 32, increased neck circumference is there. Epworth sleepiness scale is high, patient is sleepy in the daytime, scale is 16/24. Sleep study findings are AHI is positive, severe OSA, 45 per hour. Oxygen dips are there up to 76 in the sleep study. Predominantly obstructive events are there, and they are worse in supine position and REM sleep. These are one of the classic patients which we see. So how would you treat? The patient asks, do I really need to sleep with a machine at night? The patient comes and says, nahi, mujhe nahi CPAP use karna. So what would you do? To Dr. Shrija, how do you explain the diagnosis and need for treatment to this patient in simple language?
Thank you, ma'am. Thank you, Bhumika, for having me here. So this patient, clearly we can see, is a severe obstructive sleep apnea. He also has a component of positional, apnea too, and he definitely needs treatment. So I think the first step to explain to them is what is OSA. Most people don't know what OSA is, so you have to tell them that snoring is not normal. So usually they come with their wife or bed partner, and you tell them that severe snoring means that their airway is collapsing at night. So the severe snoring, think of your pharynx as a tube and it's collapsing at night, and there comes a point when it just collapses and you stop breathing. That is called an apnea, and that is when we can describe that AHI index to them, apnea, hypopnea. So apnea is closing of the airways completely, and hypopnea is almost 50% closing with a fall in the saturation. So eventually we tell them that each time your airway closes, your oxygen is falling. So your body is going into hypoxemia, and then your brain and your heart have to work that extra amount to suddenly wake you up. And this goes in a cyclical pattern, and it's a vicious cycle where you keep dozing off, your airway collapses, your oxygen falls, your heart rate goes up, BP goes up, brain wakes up. So you keep explaining, you say that in it, like if your AHI is 48, that means in an hour, 48 times is this happening. So eventually this leads to sleep fragmentation. That's why you feel like when you get up in the morning, you feel that your sleep is not refreshed, you're not, you feel drowsy during the day, you have excessive daytime sleepiness. So when they understand this point, then you tell them the treatment is something called because he's a severe OSA, we have to give him a CPAP. So CPAP is a pneumatic splint. So basically it gives you a pressure, it's a machine that you put on your face, and with a different interface. It need not be a big mask, it can be a small nasal mask, it can be a nasal pillow. So you have to make them understand that it's not an uncomfortable device, it's something that we all can use, and that it's needed. Why? Because it gives you that extra pressure which can keep your airway open. So this is what
Suppose he says, my oxygen is only falling, I will take oxygen. I don't want CPAP.
So why can't we just give oxygen? Because oxygen will not treat the hypoventilation, it will not treat the obstruction. So that is not the final solution that, where
whether you give oxygen or not, he will still not be able to take in the oxygen.
Exactly, yeah.
So thank you, Dr. Shrija. And as Dr. Shrija said, you explained the diagnosis, the problem, the risk, the need for the treatment, and the goal of treatment. So question to Dr. Vinod Chavan. Would you start CPAP, APAP, or advise in-lab titration? Patient has come with sleep study, but now next step, directly you will start CPAP or you ask for further tests?
So thank you, ma'am. So after counseling, a patient is ready for the CPAP therapy. Nowadays there are auto CPAPs are available, so there is no need to do the titration study if it is mild or moderate in cases, and no complex sleep apnea. So we can start with the simple auto CPAP device, and let's check for after a month follow-up. If patient is comfortable, we have to continue the auto CPAP. If patient is not comfortable, in case any issue, non-tolerability, then we have to go for the titration, and we can think about the other things also. Then But first attempt is to start the auto CPAP simple, as Dr. Shrija explained, with the simple nasal mask. Let the patient get used to it, and then if no compliances, any issues, then we'll think about the titration
Yeah.
and the other things.
So for this patient, since it's reasonable to start the auto CPAP straight away. If the patient still has lack of response or desaturation is still there, then we can go for a titration. In view of the more desaturation, maybe we can do the in-lab titration as well, just to make sure that with the CPAP, the oxygen level is going back up. And it is not because of some other reason that the patient is having a desaturation. So to Dr. Vishal, common reasons patient fail PAP in the first month, and how do you prevent them?
So most of the times, the patients that will come will have some or the other problems. They are not comfortable with machines, like it was mentioned before. But the kind of history that we are getting from the first case, from the case that we have been given, is it is a hypersomnia. So chances of failure are less. Male patients, chances of failure are less. We don't know the arousal values, but still, assuming that the patient has got some airway problem, and the airway problem has been diagnosed to be as only sleep apnea, then the patient will have less problems. They usually have mask fit issues, they have got leak issues, they have got some sound issues, they have fit issues, some of them have some nasal stuffiness, some of them have got nasal discharge. They may be having an infection, they may need treatment for that. If we troubleshoot these issues, I think this is how patients can get along. Many of them have a feeling that they can sleep for some time, they feel symptomatically better, and then it's the end of the story. So they may want to discontinue CPAP, which is also what we talk to them, that gradual monitoring is required. Like we do blood sugars for our diabetes patients, we have to do the AHI monitoring with the machine. The machine can read the number of hours, it reads leak data, it reads everything that we need to know about the structure of the sleep that is happening.
You asked for the compliance reports. The compliance reports from the machine.
Compliance reports, this is exactly what a compliance report comprises of, and the duration of sleep. Most of them have been sleep fragmented, or they are not sleeping on time, or they are sleeping and they are getting up too early, and they are sleeping without the masks. All of these things need to be troubleshooted on an individual case-to-case basis, and most people with some hand holding will probably get through the situations. Of course, with that also, about out of 100 patients, 40 only will break through the required results as per the recommended compliance reports. But many of them eventually understand that this is important, and then they catch on to the treatments. And options can be discussed later.
Do you normally use a humidifier when you give the patient? How often do you use the humidifier setting? Ask the patient to use.
I almost universally ask the patient, is he going to be traveling or not traveling? If the patient is going to be traveling to other places, which is what is the biggest hindrance for male patients of this age in the clinic, in the OPD, is if they are traveling too frequently, then use the humidifier at a setting. The ResMed machines, if that is not a company issue, I don't know sponsor-wise, but ResMed is having a very standardized algorithm where humidifier, if it is set on, and if the ambient humidity is on the higher level, the machine will not take the water at all. And patients also often come back and say that I put the water in the rainy season and it is not, there's no water being consumed. Last couple of weeks we've been having that. So even if the patient was using for last 1 year, in the summer season the water is being used, the winter season the water of the humidifier is used, but the machine doesn't use the humidifier unless the air has an ambient low water content. So probably I keep the humidifier on most of the times. Okay. It is the patient's requirement. If they come back and say, okay, I'm having nasal stuffiness, you go a little up. If they are saying that my nose is dry, mouth is dry, go a little up. If they say that no, water comes in and I don't want to keep maintaining it again and again, I have difficulty when I'm traveling, we consider to keep it off, if it is only that. There is also another component of heated tubings, which is there. Again, it's only available with some of the companies, not available with many of the other companies. So that is the reason why heated tubings also help the comfort level, because patient will put the mask on. For the first 20 minutes, he's probably sitting awake with it. And if they are having cold air in the nose, they feel very irritated and they want to take the mask off. These are small nitty-gritty issues, and even the tube temperature can be set. The tube of the heated
tubings for the
that can be changed. Again, so the patient
it will help also to prevent the condensation.
So all of that is taken into account, and where the patient is staying. Supposing patient is saying that, okay, I have come to consult you, but I am staying with my daughter now, I'm going to go back to Haryana, I'm going to go back to a colder environment, you have to change things accordingly. So I always believe that the humidifier and this, you give a trial and you always ask the feedback questions in the outpatient in about 1 week or after 1 month, and then you set it as per the patient's requirement. You even teach the patient how to take care, because this is a long-term therapy. So if they plan to change it in
So
future,
you
they
use
should be able
normal
to do
water
it.
for the humidifier?
No, always mineralized water, because the water that the cabinet for the heating is a metallic one which evaporates the water. So if there is any calcification or there is any scaling which develops, it leads to corrosion of that. The companies do not provide the humidifier separately many other times. So if the patient loses one or breaks one, or there is a corrosion and a wasting, so they have to buy a new machine, or they may have to buy an expensive component.
So mineralized in the sense, which one you use? Which water specifically you ask for any
Mineral
particular?
water, madam, just general
Normal
mineral
mineral
water, because it is passed through the reverse osmosis. So there is very few mineral which can give actually a problem. Distilled water is difficult for our patients to procure, and they should never be using normal saline. Saline is very high.
So distilled water or mineral water? Normal mineral
always
water.
distilled water or mineral water.
So that was quite enlightening. So yeah, same things what he spoke about. So generally, what problems do you find with the mask? Again to Dr. Vishal, for mask fitting, do you find any issues?
So mask, ma'am, actually, it's like all of us are wearing specs. They are not the same thing. If I take your specs, although you may have the same number as I do, I may not like it. It's a personalized choice. And size, like we use different size shirt, different size pants. We have to have different brands having
So
different
basically
sizes.
three, nasal pillow, nasal mask, oronasal. So which would you prefer?
Always go for nasal. That's the 90% sure shot the patient is going to like. If the patient has already previously used a full face mask, they are very hesitant to go back to a nasal mask. People who are on a nasal mask very hesitant to move to a face mask. So I always give the patient a mask in hand, try it out, put the CPAP, give a nap trial to the patient. He's a daytime sleepiness patient. He will sleep off. In 20 minutes he'll be out. When he gets up, ask him, you're okay? He said, okay. That's the mask he wants. That's it. If he gets up and tells you this mask is not okay, that means that is not okay. Change, redo.
Sure. Thank you. So question to Dr. Kapil, when should we start thinking beyond CPAP in such a patient?
Okay, ma'am. So additionally, in this patient, we'll need more, information about craniofacial features and all of that. But I agree with every point which Vishal Bhai has said. In fact, a lot of things I'm also learning. That's what I told him. But yes, my first therapy will always be to optimize the CPAP machine in whatever way. It can be a mechanical factor. It can be a personal factor. And the last point which he mentioned, majority of the patients will always prefer a nasal mask compared to a full oral. So all of us should always aim to optimize the CPAP in every single patient. However, if suppose there is a patient in which we have optimized it, but still symptomatically they're not improving, means we have to reassess clinically. Are we missing something is basically the question over here. Most probably, is there some sort of a surgical evaluation which is needed in such patients, more imaging which is needed in patients, and that is when probably we have to reassess, we have to get other specialties also involved. Dental specialists will have to be involved, sometimes ENT surgeons will have to be involved, and then we have to reassess the patient completely. If we are able to get some sort of a surgical cause in these patients, we must actually direct our treatment towards that, and then we reassess in such cases.
Sure. What kind of surgical issues might come?
So some retrognathia, so everything with regard to your mandibular position. Let's say you've got a large tongue or something. Sometimes craniofacial features or something. You've got adenotonsillar, let's say hypertrophy or something. So these are all the subsets which sometimes it's very difficult to get clinically, especially for a pulmonologist. So you will need certain imaging.
Overhanging uvula may be there. So
yes.
So sure. Thank you, Dr. Kapil. So basically residual symptoms, obesity will be there. So we could also think of correcting the obesity itself. So that could also be an additional thing which we should consider. And patient preference, anatomical obstruction we spoke about. So coming to the next one, severe OSA with obesity hypoventilation syndrome. So severe OSA with hypercapnia, nocturnal hypoxemia. So patient profile, 56-year-old female, BMI is high, severe snoring, sleepiness, morning headache. Saturation is on the lower side. PaCO2 awake is 52, so there is hypercarbia with a high, with a serum bicarbonate which is high. AHI is very high, 68 in the sleep study, and there is a lot of nocturnal hypoxemia. So we have severe OSA, but at the same time we also have obesity, hypoventilation syndrome, and sleep-related hypoxemia. We don't know, we should give CPAP, whether we should give BiPAP, we should give NIV. So how do we decide? So, a question again to Dr. Shrija. What clues would make us suspect obesity, hypoventilation syndrome in the OSA patient?
So ma'am, like this case that you've shown, so it's a spectrum, right? So severe OSA, then it's uncontrolled, patient gains more weight, morbid obesity eventually leads to this Pickwickian syndrome or obesity hypoventilation syndrome. In this, patients also have hypoventilation, which is a major part of the disease. So these patients are usually, above the age of 45, 50. They're morbidly obese. Your BMI is usually above 34, 35. These patients will be very sleepy. Even when you talk to them, you see them in the clinic, they'll just doze off in front of you. So that's a sign that the patient has continuous hypoventilation going on and maybe hypercapnic. And such patients, you can draw a serum bicarbonate or just check a venous blood sample also and find if the PCO2 is above 45 in daytime, then more or less you got the diagnosis. Like you said, this patient had signs of pulmonary hypertension and maybe right heart failure. If there's pedal edema, patient becomes excessively breathlessness during exertion. So these patients, then it should pop in your mind that these patients could have obesity hypoventilation syndrome and we need to treat them fast.
So again, about the CPAP or NIV.
So most of these patients end up needing NIV.
Most of them end up needing NIV. But you could start with a CPAP, give a CPAP trial,
Yes, so
and then
these patients
proceed.
need an in-lab titration. You will not do autopap in these patients. You will take them to a level 1 lab, do their titration, and see in CPAP if it's controlled. Otherwise, you gradually, during that session, you put the BiPAP on.
Put the BiPAP on. So question to Dr. Vinod, would you start a CPAP or would you start the patient on BiPAP NIV? And which factors would guide your choice?
In this patient is obesity hypoventilation syndrome with the severe OSA. So I'll first start the CPAP in that patient and we'll see the clinical response. Once we start the CPAP, definitely the weight reduction options are available. So we'll start, once we start the CPAP, the patients fall sleepy, proper sound sleep, and they may do the exercise and they may lose some weight. So obesity, hypoventilation syndrome can vanish it off. If no response with the initial CPAP therapy, yes, definitely I go with the BiPAP because that patient is having the raised CO2 and obesity, hypertension syndrome. So yes, if patient is not responding with the CPAP therapy, definitely as a titration study, and then we have to go for the BiPAP NIV. If patient is not compatible with the CPAP and daytime sleepiness and the CO2 raise, even after using the CPAP, if patient is not able to do the lifestyle modification and not reducing the weight, yes, then we have
So
to
the
switch to the
OHS patients with severe OSA, definitely we have to go for CPAP. We have to see the response. If the response is not good, then that means the pressure requirement may be much higher. So the patient will require a BiPAP because with a CPAP we can give only up to 20. So that titration study will help in that because we'll come to know how much pressures are required. For a OHS patient, hypoventilation patient with only mild, moderate OSA, less than AHI 30, we can go for directly the NIV itself. Because for these patients, they may require much higher pressures. So, thank you, Dr. Chavan. So we'll come to the case 2, CPAP or BiPAP. So we just discussed about that. So stable ambulatory OHS, severe OSA is dominant, you start the CPAP first. And BiPAP NIV you start earlier when there is an acute or chronic respiratory failure or OSA is mild or there is a persistent PaCO2 despite adequate CPAP, or nocturnal hypoxemia persists despite the AHI control. You control AHI, it's come to normal, but still there is a hypoxemia. Or CPAP pressure intolerance is there, or significant comorbidity is there, we can go for a BiPAP in these patients. And in-lab titration, we could start and escalate if there is hypercapnia, hypoventilation, or hypoxemia. It's not that all OHS patients require a NIV or a BiPAP. We can start with the CPAP, so as Dr. said. So question to Dr. Vishal Gupta, how do you monitor the response after starting the CPAP or NIV? Would you go by the symptoms only, or would you check the ABG? Would you check nocturnal oximetry? What would you do?
So managing a hypoventilation is itself an extreme challenge. First thing you are trying to look, I'm assuming that there was no other respiratory comorbidity. It was normal pulmonary functions, normal DLCO, normal everything else. He doesn't have any medications. All of that has been accepted that it is not there. If it is primary hypoventilation the way you are seeing it here, then in that case monitoring symptoms, arterial blood gas should be acceptable along with the compliance data. The problem usually that we often encounter is that if the arterial blood gas is still showing us low carbon dioxide, high carbon dioxide, low oxygen levels, oximetry may also be necessary because you're planning to add oxygen along with using either home NIV or home BiPAP therapy. And this is a little bit of a challenge because if you give me a choice, I would prefer to do it in in-lab and then give the patient a prescription rather than trying to do it at home by permutation and combinations. So I would personally prefer to have the in-lab done. Along with that, achieve the targets which are set out. Like for CO2, there's a target. For the OSA, there's the AHI, there's a target. If you've achieved all targets and the patient is also tolerating it well, I think that is how I would like to see the treatment and monitoring based on only these criteria. However, if the patient wants to do it at home, then a very close follow-up will be required, and along with these, I would also want to check his blood coagulation profile, D-dimer, if you are trying to look for any other complications like pulmonary thrombus or a lower limb DVT. These are possibilities with obesity patients.
Yeah.
So keeping these other obesity markers or obesity problems.
Because hypoxemia can be because of other reasons. We should not miss that.
We need to be little careful before we just say, okay, just monitor only for one thing. As a pulmonologist, I would also like to think a little out of the box.
Yeah.
Because oximetry is not easy to monitor in any of these situations. Bicarbonate is easy. Compliance data is easy for us.
For oximetry, you will need a sleep study, at
For
least a limited
oximetry,
sleep
you
study.
need the patient to take home a machine and bring it back. That is a challenge. If patient need to do a repeat sleep study, bigger challenge. So oximetry is tough, but the rest of them predominantly looks like easy. Oximetry, theoretically, of course, the machine, the BiPAP, CPAP machines or other machines have a port for the oximetry, but very few of them are the devices are available where patients can actually use it.
Use them.
There are other non-accepted methods, which like we have watches, we have got smart devices. The patients can do pulse oximetry overnight, chart it out for us. All that is not standardized, but yes, that is one of the ways that I would like to observe. More than that, sleep duration also is a way to look at it. So if the person's bed partner is complaining, he sleeps all through the day, or he has had accidents, at the same time the patient's performance in
symptom
work,
improvement.
symptoms, and objectively the person, the bed partner can say now
Sleepiness.
snoring is better and he is sleeping this time to this time. I always start the session with the first question is what time does he sleep, what time does he get up. If that starts changing, you know the patient is better. Not just the symptoms of the patient, but the observation by the bed partner.
Yes, excellent observation, Dr. Vishal. So you see for the symptoms, check oxygenation, repeat ABG, review the PAP download, see the compliance report, see the comorbid status, other reasons for the hypoxemia, and follow up in 1 to 2 weeks and 4 to 8 weeks, and escalate if there is a inadequate response, and track the serum bicarbonate. So better symptoms, as he said, and correction of hypoxemia, hypercapnia, not just a lower AHI. Question to Dr. Kapil, what is the role of weight loss, bariatric referral, anti-obesity medications, and long-term lifestyle management?
So ma'am, definitely it's got a central role, I would say. Being the only proud obese member in this panel, I completely agree with this. See, the thing is, when we are talking about OSA in an obese individual, obviously, see, obesity will be at the center of the disease, with OSA being like an appendage. And I know we are in a sleep conference and we are talking about CPAP and OHS and everything, but what we are doing is we will be concentrating only in managing that one appendage. So that should not be our focus. We have to look at the patient in a holistic approach and in a way. So the metabolic parameters of this patient obviously is extremely important, because that is where the crux of the matter is. So yes, lifestyle management, nutrition, calorie, all of that we have to manage. Now, main problem will come in two things. First is either you have to decide about a bariatric surgery, or you've got weight loss medications right now, which is thriving in the Indian market. So that is basically where we'll have to see. You obviously will involve an endocrinologist in this, because we will not be the ones who will be taking the decision
Prescribing
between
the
the
medication.
two. So yes, first probably what they will usually do is try anti-obesity medication, see what the effect is, but it's no use, it's futile in fact trying these without ensuring a background lifestyle management and everything. So all of that has to be taken into consideration, and then see. Usually if your BMI is, let's say, touching 38, 40 or something, you have to keep bariatric surgery in mind. You'll have to start the workup from a beginning stage, and then see how the patient will go. But the decision will be taken by the entire metabolic physician. In this case, it will be an endocrinologist.
Yeah.
Yes, Dr. Kapil has rightly said the obesity management, but data says that even if we manage the obesity, it helps to reduce the AHI, but not the
complete resolution.
completely eradicate the
So even
OSA.
after improvement of obesity also, the patient may still require to continue using the CPAP. So we cannot guarantee the patient that if they lose weight, they will be off the CPAP. Many patients ask, we say it may be possible, we will have to repeat the sleep study and see as per the symptoms. So weight loss goal, bariatric, anti-obesity medications and lifestyle care. So we come to the third case. So there is a snoring executive and he is refusing CPAP. He has loud snoring, he has unrefreshing sleep, he doesn't want to use a CPAP because he's traveling. Clinical profile, 38-year-old, BMI is okay. Epworth sleepiness scale is also not too bad. Sleep study findings, AHI is 18 per hour, so moderate OSA. Supine AHI is though high, 38 per hour, and lateral is less. Oxygen dip is 88, so moderate positional OSA. So it's a CPAP reluctant position. So what alternatives can you think about? So, question to Dr. Shrija. How do you decide whether this patient needs CPAP or can we manage with alternatives?
So ma'am, the patient doesn't want to use CPAP. That's the first sign that he's not going to really use it. So I think in such patients who don't have a big hypoxic burden, who don't have too much excessive daytime sleepiness, his ESS score was low.
So anyway, his chances of using it is low to compliance, adherence.
So such patients, I suppose we can, once with mild to moderate OSA, with less hypoxia, such patients you can try, like Dr. Shah mentioned, we can try the mandibular assist devices or oral appliances. Maybe we can send them to a dentist to evaluate the bite. Yeah. And if this was a positional OSA, so then
so this would be a patient whose oral assessment is very important because he's non-obese and still got a moderate OSA.
Yes, ma'am. So this patient has positional OSA, so sleeping on the side should help.
Could help.
So you can try those age-old techniques such as tennis ball vest, or nowadays you have those special pillows which are curved in one side, so they stick to one side. You have some
vibratory devices.
I've never used the vibratory device. Maybe Vishal can tell us more on that.
So they are basically devices which vibrate if you sleep on the supine position. Yeah.
And then you can, I think then you evaluate him. I think the main complaint comes from the bed partner who says that snoring is a problem. So eventually you just, after all these techniques, and of course lifestyle changes, like Vinod just said, make them, take up weight training, calorie restriction, try to lose at least 10 to 20% of weight. This should help in such patients. So
this patient I think was not so obese.
BMI?
He had 26 BMI.
Yeah, but still,
but generally that would be the way to go. So for this patient, positional therapy could work and oral evaluation and maybe mandibular advancement devices. So AHI patient is not preferring. So alternatives are positional. You could go for positional, mandibular advanced lifestyle and repeat sleep study to confirm the response. As he said, we have to see the response with the whatever treatment option we have given. So question to Dr. Vinod, what is the role of positional therapy in this case and how practical is it in the long term?
Practically, since the patient is having the positional OSA, so definitely position change will be definitely going to help him. But how to maintain that position is quite important. So there are some tricks coming up in the market to ask patient to sleep in that particular position. So I think nobody sleep in that position over the night. So practically says it's not achievable goal, but yes, the patient is having the positional OSA, then we have to ask the other specialty why that positional OSA is happening.
Yeah.
That is the main issue. So asking patient to sleep in the one position is not a solution. The rather better solution is to use the CPAP. But we have to ask the others cross specialty to find the solution, find the reason behind that positional OSA, and we have to.
And whether it can be corrected surgically or otherwise, or with a mandibular advance.
Otherwise, go for the CPAP.
Yeah. Yes. So it's useful, it may be an option, may be better tolerated. Evidence is there that it can improve AHI and ESS as well. So you have the tennis ball technique, positional belt, side sleeping pillow, vibratory positional trainer, and smartphone device assisted feedback. But you need further objective evidence that it has worked for the patient and for the follow-up. Yeah. Bhumika. So to Dr. Vishal Gupta, who is a good candidate for a mandibular advancement device?
So this is exactly the kind of patient we would like to have for mandibular advancement device. Actually, this is not a question for me because I don't select the candidate. I just select the doctor who is going to be referred to. So ideally, it has to be a person who is having mild to moderate, or the lesser the severity, the better it is. Non-hypertensive, lower BMI, somebody who is willing to undergo the procedure and also going to follow up with the doctor frequently, doesn't have TM joint problems, no pain, has good dentition. Technically, this is the most ideal scenario. I think the dentists have very well covered it in this previous talks. So I would prefer to have just that opinion, and if the patient is willing for it, then to pursue it forward, because this is actually something that feels easy for a pulmonologist to say, okay, let the dentist handle it. But we have taken feedbacks from our colleagues who are dentists who are doing the same courses in sleep, and they said that it's a very challenging thing, because people who are not willing to take CPAP, they may initially feel that, okay, the MED device is fun, they may start off, but if they don't follow it up, the results don't stick. So patient has to know that it is there. Number one, it is not more cost effective than CPAP. So the cost aspect, which is not part of the slide, is also important to discuss upfront to the patient first day and onwards. So they should know what they're getting into. Number three is, there is no mandibular retraction. You can't go back and say, okay, half traction is done, I do undo and I'll take CPAP. If you're doing it, do it first day properly and then declare CPAP is not going to be using by the patient. They can use it adjunct, but it becomes quite complicated for us because the mandible has been pulled forward. If it's a full face mask, then the mask size change, there is leaks. So that can become a trouble for everyone. So all in all, education is the foremost, most basic thing in sleep, in all parts of sleep. That is the foundation of the treatment. So ideal candidate, first thing is very well understood the disease. That means he has roamed around a lot of places, has read a lot, failed a lot. वो जो भूला भटका है वो समझदार बन जाता है, तो वो समझदार को लेना है पहला.
Okay, thank you. So Dr. Kapil, after starting oral appliance or positional therapy, how do we confirm that the treatment is actually working?
So ma'am, I think how to confirm that the treatment is working will be like, it's very similar to how even we do with our NIV and CPAP. So there will be two components. Obviously, first will be a subjective component, second will be an objective component. So subjective again will be, we'll come back to the detailed history that previously what all were, the symptoms and everything, confirm with the partner again. How much degree has it improved, what all, get an ESS again, ki pehle kitna tha, aaj kitna. So you have got, it's like a subjective component which the patient will come and tell you, and also the patient's partner. In sleep, it's always the partner whose history will be more important. Second, obviously, is the objective. So there are two ways, again, you have to repeat a sleep study at some point of time to see the decrement in the AHI. Before that, you have to, like you yourself had mentioned previously, check the data card to see what is the adherence with the treatment. So all of these, you will have objective data with you to see whether he's actually compliant on treatment, what is the percentage and everything. And then you repeat a sleep study to see the decrement in AHI. That will be how you will have to see whether the treatment is actually working.
So as you said, you see the sleep testing, dental follow-up, reassess the risk factors, check the sleep study response, check the adherence. So last case. So OSA with COPD overlap syndrome. So this we often see as pulmonologists. Like patient is a male, ex-smoker, sorry, BMI is 30, saturation is a little lower side. Patient also has snoring, apneas, daytime fatigue, chronic cough. So COPD symptoms as well as sleep apnea symptoms. And post-bronchodilator FEV1 is low, only 48%. FEV1 by FEC is 0.56. So it's COPD, severe COPD, and sleep study is also showing severe OSA. AHI is 32. Oxygen nadir is 68, and mark time below 90% saturation is there, and obstructive events with prolonged desaturation. So we have OSA and COPD, which is overlapping. So how do we go about treating this patient with oxygen, NIV, CPAP? So what more do we have to do for this patient? So question to Dr. Shrija, how is OSA COPD overlap syndrome different from isolated OSA, and why is it clinically important?
So ma'am, there are two diseases here. It's not just OSA we're treating. The issue is COPD itself leads to hypoxia and hypercarbia eventually when it goes into an advanced stage. So there are two components here, and the main issue here is that the hypoxic burden is much more as compared to just a patient of OSA alone. So an OSA patient would have intermittent hypoxia at night, whereas in COPD, the baseline hypoxia should already be there, in moderate to severe cases at least. And these patients have other complications such as repeated infections, exacerbations. So, the metabolic component is more in such patients. So these patients are at higher risk of acute coronary events, strokes, pulmonary hypertension would be worse in such patients. So in such a patient, we have to, I feel every COPD patient must be evaluated for OSA. Any patient of, severe, moderate to severe asthma or COPD, any obstructive airway disease or any long-term lung disease, even ILD patients must be evaluated for OSA in your first, repeatedly every few months. Mainly because of the hypoxic burden, and these patients might need controlled oxygen as compared to, you cannot just put them on any oxygen. You need a controlled oxygen in terms of either using a venturi and you have to monitor their ABGs frequently and, make sure that these things, and these patients usually need NIV or bypass compared to CPAP.
Yeah, so they may be not only plain CPAP, we have to also give nocturnal oxygen along with the CPAP. So how do you give that? How do you give the oxygen and the CPAP together?
So these patients, ma'am, again, in-lab titration. So I've never treated a patient like this on home basis. So if we do suspect OSA, you take them to the hospital, and again, during the sleep study, you see the oxygen and then titrate it accordingly. Start at the lowest oxygen and keep the oxygen between 90 and 93 would be enough. If a patient is hypoxic, if their baseline oxygen is less than 90.
So they use the same nasal prongs oxygen, or how
you have the ports, the masks with the, the ports we can use. In some patients who can't afford it, we use, when the patient is admitted, we use the nasal prongs too. So, but.
So you see for the OSA, the COPD, see the baseline as Dr. Shrija said. So we have covered all these topics. Also we treat the COPD obviously with the bronchodilators. So question to Dr. Vinod, would you start the CPAP or NIV in this patient, and what factors guide your choice?
So as per the case, it's a COPD OSA overlap syndrome. So first thing we have to dealing with the two diseases, OSA and a COPD. So first thing to optimize the treatment of the COPD. Then once the COPD optimization done, we have to start the CPAP. So basically the adjusting or tolerance of the auto CPAP is at a good level rather than the NIV or a BiPAP. So first we have to optimize the treatment of the COPD for this patient, and then we'll start the auto CPAP. And if even after that, because the clinical history is not suggesting the CO2 retention or something, so that patient is not requiring, as per the data, that preparation not fit for the BiPAP or NIV. So go for the CPAP therapy. If patient not improved or persistent COPD is not going under control, then we have to think about the BiPAP therapy after the initial phase of CPAP trial.
Yeah.
I'm going directly with the BiPAP.
No
And
need to
even
go
if-
for directly, yeah. So unless the CO2 level is high and you're treating also for respiratory failure, then we can consider that. Otherwise, then CPAP
Yeah,
for the
and if
OSA
the-
would be sufficient.
If the patient can, such patient can be obese sometime. So then the obesity, hyperventilation with COPD, then we can think initially to start the BiPAP rather than the CPAP. But this patient having only the COPD and OSA component.
Yeah, so you can start with the CPAP treatment. So he is basically 30, so mildly obese, and AHI was severe OSA. So you can consider the BiPAP if the CO2 is elevated, or if there is proper hypoventilation, or if there is severe COPD and your chronic hypercapnia and you're treating as a respiratory failure basically, or if they are intolerant to CPAP. Otherwise, the plain CPAP should be okay. And you check the ABG, check COPD severity, baseline bicarbonate. As you said, you rule out the obesity hypoventilation syndrome as well. So see the bicarbonate level and see the PAP titration response and history of exacerbations. Thank you. So question to Dr. Vishal, when would you add a nocturnal oxygen and what precautions are needed in a COPD patient?
I think from our COPD experience, we have better COPD experience than OSA experience. The question should be reversed actually. The question is, when do we add nocturnal oxygen to OSA patients? When the patient of COPD is already optimized. Yes, he is already optimized. If you feel that he has exercise desaturation, if he is maintaining less oxygen levels even at rest, if he needs, if the oxygen SpO2 level is dropping even below 85% on your sleep study, and you've added oxygen, if you're doing it in the lab, you have monitored it, you have optimized the COPD, but still his SpO2 level is falling, you have given him home NIV, including AVAPS or IVPS, BiPAP, and his oxygen level is not maintaining, even after the AHI is normalized, then yes, you will add oxygen as well. And there you need to monitor his SpO2 levels and his PCO2 levels
And
also.
as Dr. Shrija said, an in-lab titration would be very useful in these patients because you know with the full correction how much is the oxygen saturation, or else a home sleep study again, just to see for the nocturnal oxygen level. So because you are basically seeing whether the oxygen level is maintained or not. So is there any cutoff level below which you will start the oxygen, the saturation level?
In case of a sleep apnea patient below 85 with a normal AHI, you start SpO, you start oxygen uneventfully. If there is a cardiac issue hiding, you may be a little bit more optimistic, even below 88 you will start. So it is not a fixed criteria, this may be just arbitrary, but 85 and below you have to give SpO, you have to give oxygen in a sleep apnea patient who, irrespective of the underlying diseases, irrespective of that, if the AHI is corrected on CPAP, or on BiPAP, or on AVAPS, you have to add oxygen.
Or we can consider to just to deco if because of the OSA there are the
Pulmonary
hypertension.
Having the underlying pulmonary hypertension, we can think of the
Starting oxygen even at a higher level.
Yeah, but that is COPD.
COPD criteria will also come in. So don't give oxygen alone, use the CPAP and check the ABG, use titrated oxygen as you said. Monitor for CO2 retention, see whether the patient is going into CO2 retention after all this treatment, and prefer oxygen with the PAP or NIV. So last question, Dr. Kapil, how would you optimize long-term management beyond PAP? COPD therapy, smoking cessation, rehab, vaccination, follow-up? Obviously all, but how would you go about that?
So ma'am, again in this, I think I would again reverse this question, So first aim for us will be to completely optimize the COPD patient, from an airway disease perspective, not airway splinting perspective, but an airway disease perspective. So obviously your smoking cessation will be your priority, your pulmonary rehabilitation, ensure that there is some sort of a strength, muscle strengthening courses which the patient is undergoing in your physiotherapy. The decision, the choice of your inhalers will obviously be dependent completely on his spirometry, his history of exacerbations, and his overall, we use the GOLD criteria. In this, I think his ratio was 0.56 if I'm not mistaken. So then you have to optimize your inhalers accordingly. See if he's a frequent exacerbator variant or not, and then again your decision of ICS in these patients will be a bit critical.
Absolutely.
But for me, I would completely optimize the airway disease first and then think about optimizing the obstructive sleep apnea component rather than the opposite. Again, I'm stealing a bit of words from what Vinod Bhai and Vishal Bhai have already
Because
said.
even your nocturnal oxygen levels will depend on the optimization of the disease.
Yes, because
so
if you've
without
not
that, you cannot
optimized
say
even-
he's really hypoxic at night without having optimized. So basically you use the COPD therapy, as you said, rehabilitation, remember to vaccinate the patients, follow up, prevent the exacerbations, comorbidities, osteoporosis as well is one of the major problems. Weight management, lifestyle management, and regular follow-up, of course, is required for all the COPD patients. So yes, thank you so much. Would you all like to give any other comments, any additional comments? You can please.
So it is one of the best panel discussion, which is ideal, practical for each and everyone who's practicing in this OSA management. So because each and every point covered means from basic OSA to complex OSA to overlap syndrome with the advanced therapy also.
With one of the best slides.
So the credit for the slides goes to Dr. Bhumika, who is our AI expert. So thank you so much. So we'll wind up our, I invite Dr. Bhumika to come up for the vote of thanks. And
I would ask Jayalakshmi ma'am and Bhumika ma'am to felicitate the panelists.
Good afternoon, everybody. It is my
Jayalakshmi ma'am will felicitate Dr. Srija Nair. Ma'am, can you please come forward? Now Dr. Bhumika Madhav will felicitate Vinod Chavan sir. Dr. Jayalakshmi ma'am will felicitate Vishal Gupta sir. Sir, can you please come forward? Dr. Bhumika Madhav will felicitate Dr. Kapil Iyer. Now I would request Dr. Bhumika Madhav for the vote of thanks.
It is my privilege to propose the vote of thanks on this special occasion. First and foremost, I extend my sincere gratitude to Dr. Jayalakshmi TK ma'am, Dr. Shantesh Kaushik sir, and all the speakers who have given a talk today, and for making our sleep clinic truly memorable. My heartfelt thanks to all the moderators, all the chairpersons who have come here on a busy Sunday. And I would like to thank Apollo Hospitals, Navi Mumbai, the marketing team, Ravish, our photographer and videographer for the day, all our residents, every single person who has come here and stayed till the end on a busy Sunday morning. Thank you so much.